Fernanda, vieni a introdurre.
Non possiamo aspettare. Non lo so, però iniziamo. Quando arriva si siede. Eccola! No, non c'è problema.
Togliti lo zaino. Allora, buongiorno a tutti. Prego tutti i partecipanti di accomodarsi.
Good morning again. Please take your seat. Let's try to keep silent and start our session.
I relatori di questa prima sessione e vi volevo informare che in sala Pergamo, quindi al piano 0, sta per iniziare la sessione.
The parallel session is going to start and on the ground floor Tiziano Dauria will be there among others, so in case you're interested, please you may want to join this group. As for us, please, the speakers are kindly requested to come to the podium, and in the meantime you're having the chance to watch the list of the different sponsors that have supported us. You can read them all here.
Solid, Edgewise, aiuto se mica, Avidity, penso Santera, Wave Life Science, entrata l'ho detta e penso che siamo a posto così. Invito quindi a raggiungermi sul palco Pfizer Pepgen, ecco, grazie Ilaria. Invito a raggiungermi sul palco
Eugenio Mercuri from Policlinico Gemelli, please come to the podium. Professor Alessandra Ferlini from Ferrara and Professor Elena Pegoraro from Padua. Our clinicians, our FAB clinicians, who are going to tell us about, who are going to update us. And can I please have the first slide? Here it is. So, yesterday we heard about the updated clinical trials, both in the morning and in the afternoon, based on the different phases of the relevant study. In the afternoon we heard about some preliminary results. Now we are going into the heart of the matter, because this session is devoted to those drugs that have already been approved by some regulatory bodies or that are almost there, so to speak. Therefore, the session is going to be particularly interesting for many of you, I believe. So let us start. And let me therefore ask our first speaker, Professor Mercuri, to take the floor and come forward. As for your questions, questions will be asked at the end of the session. You'll have the chance to ask them yourselves or by sending a WhatsApp message using this number, which also goes for those who are with us online. And by the way, I'd like to thank the interpreters for their amazing work, and thank you. Thank you, interpreters. Thank the speaker and the audience. So please speak slowly so that they can best serve us. Thank you very much. See you in a minute.
Buongiorno e grazie.
Poi faccio Q&A io.
Bello tornare ogni anno e vedere che
Io faccio quello.
quindi vedere tanta gente e poi perché
So good morning. I'm very happy, of course, to be here, but also because I'm going to cope with two subjects that I'm very fond of. I'm very happy indeed to show you the results of the latest studies. So We're going to talk about two advanced development strategies. One is with the Givinostat and then the SRP 9001. I'll be going through that in a minute. So let's start with Givinostat. We all know about it since many years ago, precisely at this conference. Professor Puri told us about some clinical results with the employment of this molecule. So in Italy, we started our part two first part, so to speak. We had a share in that, and therefore we are now going to have the final approval in a few months. But what is Givinostat? Well, it is basically a very important molecule since, as we know, the lack of dystrophin and its complex entails a muscle damage, which also entails a muscle weakness. And for that, there are substances that are precisely regulated by such lack of dystrophin that may indeed increase such damage, DAC, so to speak. So Givinostat binds to these substances, basically inhibiting or at least reducing the damage mechanism, especially in terms of fibrosis and inflammation. So it's quite a different mechanism from the one we heard about yesterday, for example. So this goes directly into the muscle. Now, this means that we do act upon the muscle itself independently of dystrophin in order to reduce the deposit of fat, for example, which in clinical terms basically means that we may try to delay the disease progression. So, there's nothing terribly new about this, but we know about this disease progression. Therefore, we want to reduce such progression. Now, here are some of the studies that have been carried out. So with some muscular biopsies, we see that in time we lose some muscle, but we get more fibrosis or fat part. And the studies give us an interesting piece of evidence regarding such fibrosis and the fat. We saw it through biopsies as well as NMR. And these are the biopsies within the phase 2 of the first study. We were very happy about that. There were few sites in Italy that were involved, but such fast results showed slower disease progression, in some cases even some trend to improvement. So we got very excited about it. So we decided to plan a phase 3 study, and I'm going to, of course, sort of recap it. I'm not going through, all of these crowded slides. So NMR, MR was included too. Now, through some MR testing at the beginning and at the end of the study, we saw that the disease progression seemed to have remarkably been reduced within 1 year. It was a very important study, precisely, as I said, because it paved the way to larger studies, hopefully showing that in a phase 3 study with a placebo group and a larger population, the drug could actually turn to be effective and also available. So after the initial study, other studies followed. You can see them here. The phase 3 study is, of course, the most important one, but we're also going to talk about the Ulysses study, which regards non-ambulatory boys older than 9 years old, whereas the main study is mainly for ambulatory boys and of a younger age. And here is the study that will hopefully take us to the approval of the drug in quite a short time. The endpoint was to demonstrate both the efficacy and the tolerance of this drug in ambulatory DMD patients. There was a screening part, and then 18 months of treatment, 72 weeks. In other, if we put it differently, and we must, this is something very important. I mean, we must agree with the families about the need for us to actually need some more time. Some families tell us, look, the placebo, my son in a placebo group for over 12 months. Well, we disagree about that. But sometimes we need that to be the case because we must see whether the drug is effective or not. And unless we get the family's agreement, we will never get the approval of our studies and drugs. So we decided we should extend the initial 48 weeks to 72, as I said, further to which the main study phase was suspended, and we moved to the current phase, basically. Here are the key eligibility criteria of the study, very rigorous ones. Some families were not happy about that. But as some speakers said yesterday, we need to be very strict about having a homogeneous population. Otherwise our studies would be, I don't know, 10 years long. And actually, the population here, there was a main population with even stricter criteria, I might add. And then there was a sort of a sub-population, very important too, though, especially in terms of considering the safety of the drug. Now, the primary endpoint of the study was to show the presence of a difference about between the walking abilities, mainly walking, up steps of abilities of treated and untreated boys. So statistics is there, of course, but we did manage to meet such criteria. So there was a statistically significant difference between the treated and the untreated boys. You can see that on the right-hand side. But please notice the results after 9 or 12 and then 18 months. If we had stopped at 12 months, statistical significance would not have been there. Curves, as you can see, started detaching a bit one from the other. But if we had stopped here, namely at 12 months, the study would have not been significant. The drug would have not been included in the approval phase. Whereas now, this is a significant study, so statistical significance is there, all right, and hopefully this will lead us to its approval. Now, the primary endpoint So the primary endpoint but was basically stable all through the different scales, the NORTARC, but also the other, testing scales. And then the MR was an objective test. People say that, with other testing, there may be, a relevant human factor, whereas with MR, it's quite an objective kind of data that we get. And here we seem to have full agreement among all the data that were gathered from the different testing activities. Now, for many years, we got quite frustrated because we could not see any achievements, whereas now we seem to have this study that will, as I said, hopefully get to the drug approval by the regulatory bodies. So North Star is a very famous scale that I believe all families are familiar with. It is quite a complex scale, including 17 activities, each one of which is very important for daily life. So not losing points here means not losing points in the boy's daily life. There may be some decline, which is, however, much less relevant than, of course, in treated ones than in the untreated ones. So very good results, all thanks to MR. You can see that through the chemical pictures, but we get, in any case, data that seem to be shared. In other words, there is a difference, a clear-cut difference between treated and untreated children. What about safety? Well, actually, there have been some side effects here. Some boys had a reduction in platelets. Otherwise, lipids went up. But I mean, these are side effects that we managed to keep under control. There was a time when we needed to reduce the initial dosage, which had been envisaged by the protocol, by the way, in case of different values in this respect. We knew we would have to reduce the dosage. So we did keep that all under control. Of course, everything had to be monitored, and I'm, saying that to you too. I mean, if the drug is approved, monitoring must be carried out. Anyway, it's good enough for us to see that there were no severe side effects, or in case there were some, they were not related to the drug taking. Interestingly enough, as with all drugs, I would like to say that once again, monitoring is of paramount importance, which includes, of course, the detection of the right dosage. So, I said a reduction in platelets or an increase in lipids. All of that led to a decreasing of the dosages. But as for platelets, of course, you know how important they may be for the sake of bleeding, but actually there were no such clinical outcomes. So to recap, we're very happy because we now have a study that has a relevant statistical significance. Actually, this means that the differences that have been seen are significant in their own right. The decline that was not showed by the MR that tells us a lot about the disease progression is certainly something very important. And it's very nice for us to be here and discuss about these data. Also because we might add that hopefully the drug will soon be made available, but at the same time people are working at possibly employing this drug with both younger and older patients. So that was a success story. Very good, for once. But here is another success story, which is in an even earlier phase. This is another study with a molecule already included in phase 1 and phase 2 studies carried out with Sarepta and Roche. So gene therapy, once again, I decided I should take many slides off because yesterday you heard from Professor Previtali and other speakers much that I would have told you today. So Here is a slide concerning this product. There's a microdystrophin, which includes that includes some essential components to have a good dystrophin function. And I am here today due to time constraints to only talk to you about this study, the Embark study, the first phase 3 study where this molecule is used. So again, treated and untreated groups, and after 1 year, the groups were switched. So the treated became untreated and the other way around. And we were not aware of which was which, so to speak. Well, we actually got some clinical signs that might have, spoken for one group or the other, but nothing else. So homogeneity is once again a key factor, but the primary endpoint is the functional scale at 12 months, and then some secondary endpoints were always, of course, related to time-related testing. So here is the population before, before 4 years of age and after 8 years of age. Either from 4 to 5 years or from 6 to 7. Well, that was basically the population that we considered, as a matter of fact. Now, very good results, very good results. Actually, what is on the right-hand side tells us that treated patients do better than untreated ones. On the left-hand side, exactly the opposite. But in this case, as you can see, all results seem to take us to the same direction, because the treated group seems to always do better than the untreated one. In this case, though, the problem was about the North Star, the primary endpoint at 12 months. Well, at that time, again, the data were very good, without, however, ever reaching a statistical significance. Hence the problem. In other words, the measures may be right, but the length of the study may not be right. You'll probably hear from other speakers that also with other studies, whenever we work within the framework of that study for a relatively short time, data may be good without, however, ever getting statistically significant. Hence the relevance of the time of the study. This is something we must very well keep in mind. I'll also show you a follow-up of the previous study. Well, this study may have suffered a bit from such a short time, only 12 months. Coping with the placebo group might not be, might be more difficult otherwise. If we had gone over those 12 months, we would have got better results probably, but definitely statistically significant. So the blue one accounts for the statistical significance. We must truly and deeply understand that it takes some time for these drugs to actually show their effectiveness. You're going to see graphs from other studies on other molecules, but you'll also see that after 1 year, there is a sort of a detachment, At 12 months, there is a detachment between the two curves, but at 18 months, the curves seem to be even more distant one from the other. This must be made clear also to the regulatory bodies who keep not approving our studies that after 1 year show good data, but according to them, not statistically significant. There's a good P, as we say, but not statistically significant. Now, I'd like to stress this independently of the molecule that I'm talking about right now. I mean, just look at this graph. Here you see that, as it always goes with these studies, the treated group may be better than the untreated one, but that is no coincidence. So if the P in question does not reach any statistical significance, well, this might tell us something about the study design, mainly in terms of its length. So once again, good for us to see that all the data are located on the right-hand side. Especially, I'm thinking of this ability monitoring activities. Well, once again, there is a statistical significance here too, and the difference is even clearer when we compare younger and older patients. Younger patients seem to do better, probably because the muscle is better kept. There's a least advanced decline, so it takes shorter for us to have good, or to see rather, good results. So they definitely seem to do better. Now, adverse events. You heard yesterday about severe adverse events in some studies. And now, as a clinician, let me tell you that in this study, we basically noticed two things. First of all, the amount of boys having the antibodies to this vector, not the AV9 that you heard about yesterday, was very low. I mean, no antibodies were, none of our patients had these antibodies. And secondly, we saw a lesser amount of side effects when the gene therapy was administered. We did that also for other diseases, and we usually get a certain number of patients showing some side effects. ALT, for example, was one of the altered, the modified values, but that does not seem to be the case here. Well, of course, there were adverse events due to something that may have nothing to do with the treatment itself. But as for the actually treated-related events, well, they accounted for a very small amount, especially if we consider the serious or the severe ones. So we may say that, generally speaking, this drug seems to be a good one. So interesting data, but let me now show you this slide about long-term data. Now, in the first study, when we first used this molecule, only 4 children were tested, and here are the results after 4 years of these 4 boys. Now, independently of the age at which they were tested, which varied, well, some improvement seemed to be there at the beginning. Just watch the first graph. Every group of rows counts for a single boy. So there is some improvement, which is quite good. But after 4 years, the improvement seems to have turned stable, which is even better, to hear. Whenever I talk to families, actually, I am a clinician. We clinicians often find it difficult to talk about families' expectations. When we think of gene therapy, we are aware of the fact that we have expectations. However, let us just stick to that. After 4 years, in the meantime, these boys may have turned, 10 or 11. Well, then there is stability. The situation is stable. Well, I would, I would be very happy if that were always the case. I can understand, of course, about families' expectations, but expectations should be the right ones, because in this way you will never be disappointed, and you will also be able to understand the actual relevance of results like this. So we need a mind shift to better understand the meaning of, the length of the trial. If this study could show after 4 years this kind of result, well, it would be great. It would be truly great. Maybe stability could even be followed by some improvement. I mean, we know that unless we give them some treatments, such as stability at 4 years will never be the case. So I have told you 2 success stories. I believe they are very similar stories. Of course, we still need to wait some time for at least one of them. But I thought this slide could be truly something hopeful for us. And once again, it's all about expectations. Families often ask us questions about their expectations. Now, I'm not being simplistic. I just want you to understand the relevance of having the right expectations. So, gene therapies are going well. Apparently, when we started, safety was our main worry, because such a high vector dosages had never been administered. But luckily enough, apart from a few cases that we mentioned last year, well, this is no longer the case. So we get initial improvement, then stabilization. Well, that's very promising indeed, and it's nice for us to think that maybe in a few years we'll be here talking about possible combination therapies, through the combination of all these drugs. So expectations, full understanding, and we need to have you on our side, when we talk about the length of the study, because otherwise we might no longer have such good results as those ones. Let me conclude by saying that we are now going to start with another study that is it, indeed. It was a bit difficult to start here in Europe because some aspects could not be validated in this in Europe, indeed. Anyway, now we are starting. The name of the study is ENVOL. The endpoint is to have good safety, at 4 years or, even longer than that. So let me conclude with this study, which is a larger one. Its name is ENVISION, and this study will allow us to use gene therapy in a clinical trial, but in older patients. They may have not been ambulatory anymore, but older patients in any case. So we got the approval from the Italian ministry, and I believe next month we're going to start this study. So once again, good news, and let me conclude by thanking, of course, the association, the parent project Italy, but families, the families, these studies are not there for free, so to speak. In other words, you must pay a price. You must go and come back to the site to watch the platelet reduction, for example. I mean, we need families to be fully involved and committed, because sometimes it's very hard for them. So I would particularly like to thank them, and of course the boys, because they are the ones whose blood must be taken, for example. And I'd like to thank my staff. Thank you very much.
Bene, continuiamo. Well, we go on with this drugs.
Oggi di altre due molecole che sono in una fase avanzata di sviluppo.
So these are the drugs that are quite advanced. The Vamorolone, that is the therapy for the nonsense mutations. And these are things that you all know, the lack of dystrophin in the muscle that is total in DMD patients creates a fragility of muscle fibers that undergo these repeated cycles of degeneration and ineffective regeneration. In the early phases of the disease, you have inflammation. In a late phase, you have fibrosis, which means losing function. There are two therapeutical approaches to Duchenne. First of all, the therapies that try to restore dystrophin, many have been mentioned, and other therapies that refer to downstream phenomena, so all those secondary phenomena that takes place in the muscle because there is no dystrophin. So the two molecules are Vamorolone, that is a therapy that acts downstream, so trying to mitigate the effects of the lack of dystrophin in the muscle, and that can be used by all patients. On the other side, we have Eteplirsen, that is a molecule that helps reading through early stop codons in the nonsense mutation. That is tailored, personalized medicine, and that applies only to patients who have a nonsense mutation. In Italy, it is 10.5% of the whole population, and in some areas also 12-13%. Vamorolone first. What do we know about glucocorticoids in DMD? Well, the first drug that was used was a very effective one because it slows down the progression of the strength deficit, and by slowing down the progression, delays the loss of ambulation by 18 or 20 months. It not only involves the lower limbs, but also there is an improvement of function in the upper limbs, as well as the respiratory function and the heart function. So this evidence started in the 70s. The mechanism of action of cortisone is not fully understood, but certainly there is an anti-inflammatory effect, stimulation of tissue repair, stabilization of the membrane. But we have cortisone. Cortisone is effective, but there are side effects. Whoever has a child taking cortisone knows of children taking cortisone. Well, you are aware of the side effects. Well, where there is a growth delay, so the treated children grow less rapidly. There is a weight increase. The bone becomes fragile because there is an early disappearance of calcium and bone structure, and other side effects, irritability, alteration of the behavior, and so on. So we have a drug that is very effective, but which has important side effects. And in this framework, we had the need of finding a drug that can confirm the beneficial effects of cortisone while reducing the number of side effects. And they are called dissociative steroids. Why is it dissociative? It keeps the beneficial effects but reduces side effects. In this scenario of reduction of side effects, well, we find Vamorolone. The Vamorolone is the first drug in this group that was designed by simply modifying the structure of the molecule of the steroids, adding a double binding and losing hydrogen. And this drug still has the beneficial effect of cortisone by a reduction. So it has this anti-inflammatory activity, but it reduces side effects and protects the bone, thus enabling the treated children to have a good growth rate, similar to that of healthy subjects. Vamorolone, as any other drug mentioned today, of course, it must go through the different phases of development. First, healthy volunteers, and then small open trials where all the patients take the drug simply to assess its safety. And then you go on and you reach other studies that are called double-blind. But these open trials have demonstrated that vamorolone, well, in orange, you see a population of patients taking classic cortisone products. This data come from this synergy. This is an international research group for the natural history of DMD. And if we compare the orange with the blue, so if we compare the orange line with the blue line, these are efficacy tests. So these are this time-related tests. And so vamorolone has the same efficacy in slowing down the progression of the disease. But if vamorolone, well, if we see the growth of these children, we can see that the patients treated with prednisone or deflazacort grow less well than treated patients, whereas those that take vamorolone have a growth curve that is similar to that of normal children. So this is what makes it different from the other cortisone drug. From the regulatory viewpoint, you must have a controlled double-blind study, and this is the study that is called 004, and it is made up of 2 intervals of observation. First, 24 weeks, where the patients were stratified with 2 different doses of vamorolone. You see there 2 and 6, and then there was an arm with prednisone and another arm in placebo. After 24 weeks, the patients who received the placebo or the prednisone were shifted either to 2 or 6 milligrams per kilo of vamorolone. And then the data were checked at the 24th and at the 48th week. There it is important to have an extended observation over time, because we must see not only an improvement over time, but also we must be sure that it stays also. It's present also in a longer time. Here you see these are all timed items. So the speed for some tasks, for example, getting up from the floor or walking for 10 meters. This is the 6-minute walking test. And you see that if compared to placebo, that is the black line, patients treated with vamorolone with the 2 different doses, you see that the 2 curves are very different, and the difference is statistically significant. And this is what we hoped for. We hoped that it would maintain the effect without having so many side effects. Here we have a higher number of items, but you can see that the placebo arm has a worsening over time. If compared to the baseline, you see that patients get worse, whereas the purple one, vamorolone 6 milligrams and prednisone is the green one. Well, there is no statistically significant difference between the 2, which well, shows that the drug is effective. 48 weeks, we have a stabilization of the effect. And for 2 items, that is the 6-minute walking test and the speed in going up 4 steps, we have a gradual improvement. What happens in patients that initially took the placebo and then were switched to Vamorolone after 24 weeks. Well, the patients that take the placebo tend to reach the same functional levels as those who have taken Vamorolone for the whole time. The same applies for patients who initially took prednisone. In the first 34 weeks, the two curves overlap, but when the prednisone patients switch to Vamorolone, you see the same results. So Vamorolone is effective just as much as prednisone in slowing down the progression of the disease. But let's consider side effects. And that was the rationale, precisely, the reason why we wanted to study this new molecule. So these side effects for the Vamorolone population, were lower than that of those being treated with classic steroids. And the difference was very clear for the most serious adverse events. The growth curve, if compared to placebo, and prednisone is the red line, and the two doses of Vamorolone, you see that the growth in height of these boys is clear, and the switch from prednisone to Vamorolone in patients precisely who had been treated with prednisone initially, they are just as tall as the boys that had been treated with Vamorolone since the beginning. We said, that the growth was better, there were less side effects, especially in terms of behavioral problems. And then in this study, there was also the monitoring of some biomarkers pertaining to the bone health. These markers, tell us about the ability of the bone to produce bone. So patients, you see there, light blue, the markers are increasing. In the switch from prednisone to Vamorolone, you have a significant increase also in the group that initially had been treated with prednisone. In conclusion, Vamorolone has demonstrated to improve the motor function, reducing the most relevant side effects. So the patients that have been treated with Vamorolone are quicker in getting up from the floor, in walking, in going upstairs, and we have also demonstrated a stability, at least for the window of observation, that is 48 weeks. So stability of the parameters, a reduction of side effects, there is a good preservation of the bone mechanism, normal growth curve, and a reduction of the severity, especially with regard to behavioral disorders. Where are we with Vamorolone? It was approved by FDA in October 2023, EMA December 2023, and now we are waiting for the approval by IFA. So these are the sponsors that have made this study possible. This is as far as Vamorolone is concerned. So this is possible for all DMD patients. Now we switch to the second drug, Ataluren. We have a sort of regulatory odyssey. I'll report you the story of this molecule. It is a small bioactive molecule. It must be taken per os. Ataluren identifies this early stop codon in the nonsense mutation. This tells the cell the protein is finished, but this stop signal takes place very early, happens very early. So the cell is unable to form a model protein. This is a nonsense mutation. Then I'll show you a cartoon, and this Ataluren helps skip this mutation and go on with the production of protein. This is the first drug approved in Europe for nonsense mutations, and it is a therapy that is only for patients who have a nonsense mutation in DMD. DMD gene. This is what normally happens. We have this filament containing all the information to produce dystrophin. There is a physiological stop codon the cell reads the protein is ripe, stop, and then the protein is released. In patients who have an early stop codon, this is read by the cell as stop, the protein is completed, whereas the protein has not been completed, so it's not active. This is an incomplete protein that is biodegradable easily and has no function in the muscle. If we use ataluren, the objective of ataluren is going on reading the information and then synthesizing a protein that is modified by ataluren. So it is not a normal dystrophin, it is a modified dystrophin, but it still has functional abilities that should guarantee a functional improvement for the patient. It is a regulatory odyssey because the first study is a double-blind study that had as primary endpoint demonstrating that treated patients would have walked longer in the 6-minute walking test. This primary endpoint was not reached just for a few meters. So in 2014, the EMA released a conditional approval. Why? Well, because the population had no other therapeutic alternatives, and because the finding still showed a favorable effect of ataluren, so the patients, the treated patients could walk longer in the 6-minute walking start, and they were faster in the other timed items. Another double-blind study, this is ACT-DMD. This is a controlled double-blind placebo study. We enrolled 230 patients, and the dose is the standard one, 40 milligrams per kilo, administered 10, 10, and 20. So the last dose of the day is twice the initial ones, and the primary endpoint is again the distance walked in the 6-minute walking test. And this is a very important study because it taught us many things, such as the following. Well, if we consider the whole population involved in this study, at the end of these 48 weeks of observation, we see that ataluren has a benefit of about 13 meters, and one may wonder what are the results that we consider clinically significant. But if we go beyond that and we see what is the result in children who entered the study when they were very weak, well, we see that ataluren has no significant effect, and the same goes for the other extreme, for those who were very strong. The difference is clinically significant when we considered a specific subpopulation of patients that was also identified in the endpoint of this study. So patients who could walk more than 300 and less than 400 meters. We know that in DMD we have a first period where children are strong because they grow, because there is an increase in muscle mass, and then there is a third period where there is an advanced disease where the children are already very weak, and there is an optimal time of observation where there is a decrease in force, but for this lapse of time, we can get some benefits. So in this subpopulation of patients, ataluren proved to be highly significant. The beneficial effect was highly beneficial. Not only the 6-minute walking test, because clinical effectiveness could be assessed in different ways, but also in the NSAA. There are 17 items. In blue, you see the placebo, and you see the percentage number of patients losing the function, and the placebo patients were more than those who took Ataluren. So on the basis of this study, even though the primary goal of the study was demonstrating an increase in the distance walked of more than 30 meters, and if the group had been specified, so we could not reach statistical significance in the whole population, but still we had conditional approval for the marketing of the drug. So the company is asked to provide further evidence. And so we collected the data in a register, and we carried out a new controlled double-blind study. And this is the 041 study. This is an international clinical study. Well, from 48 weeks, we went up to 72 weeks, which means 18 months of treatment. And there were two arms, the placebo arm and the Ataluren arm. There again, the design of the study was extremely complicated because apart from assessing the effect of the drug on the whole population, we also identified two subgroups of patients. The patients who walked more than 300 and less than 400 meters, and those were the patients who had more benefits, but also another subgroup of patients who walked more than 300 meters, but for whom that required more than 5 seconds to get up from the floor. So they were strong, but they were slow at carrying out some functions. So there was already a decrease in function. Let's have a look at the result of this study. From the regulatory viewpoint, clinical studies require that the primary endpoint is reached. Patients treated with Ataluren have a functional advantage if compared to the patients treated with placebo. This is the 6-meter walking test, and the orange patients, the orange are those who were treated with Ataluren, have a 20%, 21% slower progression versus placebo. If we consider patients who lose ambulation in the two groups, twice as much for placebo, so 12 versus 20, 6.6, 11.4. If we consider the pre-specified subgroups, we observe that in the first subgroup, there is an increase in the functional benefit of Ataluren, whereas in the other subgroup, statistical significance is not reached. So they can still walk 300 meters, but they are a bit slow in timed items. But as for the losing ambulation, you see 5 patients in the Ataluren group lose the ambulation against 10 in the placebo. Other functional scales, a clear advantage of Ataluren patients, and here they are the orange centiles. This is NSAA, and the Ataluren patients lose less versus the placebo. In the two subgroups, again, we see what we have seen for the 6-minute walking test. Well, you see the pre-specified subgroups, well, the difference doesn't reach statistical significance. In timed items, we have the same trend. So if we consider the whole population, and there is an advantage in the subpopulation between 300 and 400 meters, and some loss of statistical significance in the subgroup that could walk more than 300 meters was a bit slower in getting up from the floor. So now we are going into details, because this pre-specified subgroups means that before starting a trial, we can properly identify the population that will get a maximum advantage. But in a general situation of advantage of Ataluren versus the placebo, the safety of the drug, both in this study and in other studies, was excellent. Very few side effects and not clinically significant, so safety is there. In order to have better evidence of the efficacy of ataluren, a meta-analysis was carried out. It is a statistical method whereby we put together the data of different studies of patients treated with the same drug, but there the whole population is taken together to see whether the parameters we have observed in one group and in a small number of patients, relatively small. Well, if you have a rare disease and you have a subgroup there, of course, the numbers are already good enough. So there was the meta-analysis on the first study that led to the first conditional approval, and the second study, second conditional approval, third study on the basis of which we had the first results, the first approval. And here you see the number of patients included in the meta-analysis. If we look at the whole population, and there we're speaking of 700 DMD with nonsense mutation, all the scores that are to the right of the central line are in favor of ataluren, whereas all the scores to the left are those telling us that the placebo is just as good as the drug. And for all the items that were identified, timed items, North Star, and 6-minute walking test, the patients treated with ataluren do better over time if compared to placebo patients and reach a high statistical significance. If we consider the subpopulation of patients that have a linear phase of progression of deficit of strength, and we test the 6-minute walking test, the treated patients walk more than 33.7 meters versus the placebo. This hasn't been sufficient yet. We had to prepare a register. These are the post-marketing registers. After the approval of a drug, these registers collect the evidence of real life. So it's not a super controlled setting such as the one of a clinical study where you have very binding parameters, controls, and so on and so forth. There you collect data of children treated in a normal prescription, in a normal situation. This is the register is called STRIDE, Strategic Targeting of Registries and International Database of Excellence. They collected data from 68 centers in 16 nations. And more than about 80% of the patients took ataluren for more than 4 years, and a lower number of patients took it for less than 2 years. So these are patients followed with clinical standard for a very long period of time. Inclusion criteria, taking ataluren, older than 2 and ambulant when the data were written on the registry. But we must have something to compare this data with, because otherwise we can just observe. So the group of control was collected by this synergy. This is an international cooperative group that devoted its activity to collect the so-called natural history data of DMD. Natural history is not the appropriate term because anyway they are all treated with cortisone, that we know that it is a drug that modifies the natural history of the disease. When we take two groups of patients to have a comparison that is meaningful, a priori we must consider that at baseline the two groups of patients are comparable, because if we compare data from the registry with patients that do very well or with patients that do very, very poorly, well, it wouldn't work. So we must match the two populations, which is not easy because the data of the Synergy registry are very heterogeneous, or we use the statistical algorithm and propension score. So we use these parameters: beginning of the symptoms, beginning of the steroid therapy, beginning of the use of the deflazacort and the other glucocorticoids. So we had sort of copies of the patients who are in the STRIDE group and the synergy group. And this system proved to be effective, because when we compare the two groups before the use of using this coupling algorithm, you see that there is a statistically significant difference between the two groups. But if we use this matching algorithm, the two populations perfectly overlap. And so let's analyze the data of this registry. The patients taking Ataluren, it is the red line, walk on average 3 to 5 years longer than the patients who only take corticoids. So the standard cure, the standard therapy. So better, if you work for a longer time, you have better respiratory function, and forced vital capacity under 60% takes place 2 years later than what happens in placebo patients. So Ataluren is advantageous if compared with the placebo treatment. As for safety, well, the safety profile is excellent in all the studies carried out so far. As for efficacy, the study at 18 months has demonstrated efficacy with a number of motor functions in the whole population, and only and very much so in the pre-specified subgroup between 300 and 400 meters walking ability. If we put together all the data, more than 700 patients have demonstrated that Ataluren delays the loss of the motor functions if compared with the placebo patients, and the STRIDE registry data confirm the efficacy of Ataluren. What we want to underline is that the identification of the efficacy measures are really subdivided in very small items, and in some subgroups, well, the effect of the drug doesn't reach statistical significance. Where are we? First, conditional approval in 2014, and then they asked us this post-marketing registry, the STRIDE registry. Then in 2019, we had the second conditional approval, and they asked us a double-blind study for a longer period of time. Then in 2021, I mean, regulators anyway considered that the drug was effective, so they also authorized the drug for children over the age of 2. So they initially it was ambulant children above age 5, but in September 2023, this commission expressed the first negative opinion that was repeated in January 2024. And now, to know what the destiny of Ataluren will be, well, we'll wait for the European Commission decision. PTC Therapeutics is the company that is behind all these studies. Thank you.
Ok, buongiorno. Allora, adesso diciamo.
Good morning everybody. I would like to particularly welcome the parent project families. So, what I'm supposed to do is the following. To tell you about the current therapeutical approach to DMD based on AONs. Well, we call it in a different way somehow, because these are basically molecules including bases that precisely make up the DNA molecule, the DNA, well, as a whole. Well, I might add that was quite a transformative approach. We like this molecule very much, and this is part of our story, because when we first started our trials with antisense, actually Annemieke Artsma-Rusch is, I understand, in the audience, and therefore I wish to recall at this stage the relevant role played by the Leiden group. Thank you very much. Where are you? Where are you, Annemieke? Are you somewhere? Okay. So, maybe not now. So, my presentation is going to be about these AONs, some of which have already been approved in the US, but anyway, they are being worked at by two different companies. One of them is Sarepta. So RNA therapies is the way we call these therapies. Well, this is, of course, the disclaimer. So I'm very happy to be here and talk to you about these molecules because the presentation has been prepared and approved by both companies. So exon skipping. Here is a therapeutical approach whereby everything orbits around removing and not adding. Well, that is quite philosophical, So if you were to add, you would, for example, administer a drug. But exon skipping basically removes by the dystrophin transcript an exon in order to restore the reading frame, which is very important, of course. That is the way our RNA molecule is read and then used in order to precisely produce dystrophin. So this is quite a well-known seeing such exon skipping of only three exons, namely 45, 53, and 51, so that we mask them so that they are not seen, so to speak. Well, then we can treat as many as 30% of our patients, which is, quite good. We actually know that DMD includes the so-called deletions, which, as you know, account for even over 60% of our patients. So 30% possible treatment, well, is quite good after all. So this is Sarepta's pipeline. Again, the exons involved are the three I mentioned before. Of course, exon 51 is the one that was first coped with by all DMD approaches. Actually, today we know that there are actual drugs. There's Eteplirsen for exon 51 and two more for the other two exons. They are all in Sarepta's pipeline. So the clinical trials phase 3 has already been is already behind us, and there's also been an FDA approval. And of course, other therapies are being experienced by Sarepta for other exons. Now, as it goes with all the drugs I'm going to talk about today, it must be said that these are very weak products, if you wish. Therefore, they need to be made more stable by the so-called backbone. Well, here the backbone, such a chemical, scaffold is basically the one that is known as Morpholino. So stability comes out of it. However, this also entails, a certain degree of neutrality, which is not very good to hear. But the point, which may be good enough, is that it is administered via an intravenous injection. So, such neutrality has the downside of not allowing for much interaction. So the targeting, of course, may not be fully compliant with our ambitions and expectations. Now, antisense molecules are effective at the nucleus, so the point is not that they should simply enter the myocell. They should actually enter its nucleus. This is our aim, of course. So, this is a sort of a recap regarding the safety of Eteplirsen. Very interesting data regarding the lungs, for example, and regarding survival as a whole. And then, if we use dystrophin as a pharmacodynamic marker, then we'll see that dystrophin production is increased from 0.8 to 0.93%. And as for over 180 patients that were treated, there were no real side effects in terms of safety. Plus, there was some remarkable improvement regarding ambulation, and even more so regarding the respiratory function. And as for survival, once again, there's an average increase of some 2 years or so. So here is the total amount of data regarding Eteplirsen. Well, Eugenio is much better than me in showing you these data. But anyway, on the right-hand side, you see the survival curves with a statistically significant increase of such a survival in treated patients treated with Eteplirsen. So this is a summary that I asked Sarepta to include, especially for the first item in this list. You see here an improvement of 5.7 years freedom of ventilation, which I believe is highly relevant, especially because boys can feel how good that is. And then there's also an average increase in ambulation by 2.7 years, and the same goes for many other vital parameters. As for Golodirsen, so here is another antisense molecule. It's a PMO again. Here we're talking about the exon 53 skipping. We get here too an increase in the dystrophin production in the muscle. Unfortunately, muscular biopsies are still key to the treatment of our boys. Anyway, safety profile is good too, indeed excellent, and the same goes with ambulation and with pulmonary functional data, where we get remarkably higher percentage. Now, here are the data for the Golodirsen long-term use update. This is the slide Sarepta included in my presentation, which is certainly one that is quite typical of this drug. And this is the same graph as before regarding ambulation. As you can see, these patients lose their ambulation after 2.7 years plus, of course, the years that usually make up the actual length at which they lose ambulation. So there's a definite, a positive improvement. And here is another molecule, Casimersen, for exon 45 skipping. Dystrophin production is definitely increased. And in terms of the safety profile, once again, we get very good data, which also goes for functional outcomes. So let me now move on to the EVOLVE trial. It is currently underway in the US. It is a long-term observational study evaluating the effect of the three above-mentioned molecules in a larger population of patients enrolled in December 2021, or rather as of December 2021. So it's a long-term study. The basic difference with the previous studies is basically this one, and I feel like the approach is similar to the one of the STRIDE. Well, basically because it's an observational study, possibly for no other reasons. So anyway, here you see the different data showed by the EVOLVE study. That is a bit crowded, so I won't really go through that. But anyway, it's about the parameters used in this study. We'll probably go into further details when hopefully we'll have that in Europe too. And here is the summary of the several of the various Sarepta studies, Essence, for example, and Mission. Both studies, well, for both studies, recruitment is still open. The Mission study is particularly relevant since it is the first one for Eteplirsen in Europe. So the idea is that hopefully this molecule will also be approved by the European regulatory body. And this is for Italy. Well, here is the list of studies that are being carried out by Eugenio at Policlinico Gemelli, but other sites are involved too: Milano, Genoa, Ferrara, and Messina. Well, I always tell companies that Italy is long and narrow, so it's not that easy, you know, for families to cope with the need to reach a given site for a long-term participation in a study. And now Viltepso, also known as Viltolarsen from NS-Pharma. That's the second company I want to talk about. So here there is an exon 51 skipping. Therefore, we might wonder about the differences with the previous study. This one has only been approved in the US US and Japan. I might add Japan because it was first published by Japanese authors. So the two molecules are both antisense. They both concern exon 53. They are basically PMO, both of them. PMOs. However, here we have 21 and the other one is 25. I mean, the length of the molecule has this difference of the two molecules, which also has some rebounds on the chemical aspect and the target ability of both molecules, which may indeed, change a lot. So it's not exactly the same thing. So there was an FDA approval with a recommended dose of 80 kilograms, 80 per kilograms. Now, in terms of safety, we get quite good data. I mean, side effects or serious side effects did not basically occur. But of course, there are some clearance organs that are involved because we use an intravenous administration. Therefore, there may have been some involvement of the clearance organs, but we did not get that. So apparently there wasn't precisely because of that kind of administration. The liver, for example, seemed to show no serious side effects. So 80 milligrams per kilogram, as I said before, this is the FDA recommended dosage. There's a low dose arm and a placebo arm in this study, quite interestingly, only for 2 patients and only lasting 4 weeks. Further to which, I mean, from the placebo group, the patients moved back to the low dose arm. So it seems like there are 3 different groups, but actually 2.5, we might say. Dosage, however, is the same, always 80 milligrams per kilo. So here you see the lengths, the different lengths involved, which take us to the open label, the extension study that is still underway. So here are some study details, about the population, about the endpoint, the dosing. So as for the endpoint, dystrophin levels were basically the primary endpoint. The study authors have been very strict about this, but there are also some secondary endpoints, basically the exon skipping, but all the motor functions. So that was the study design. Now, what about the results? As for the primary endpoint, so the dystrophin production, well, data were very impressive. There was a 5-time increase in dystrophin production after 25 weeks, during which 8 patients were treated, and measurement took place with the Western blot, as it is usually the case. That is for the safety profile. You see here the different adverse reactions, none of which, though, was related to the actual drug. Here, please just only look at the right-hand side of the slide. There's a, continuing dose, and there may be some differences in terms of the weight of every single patient. As for the motor functions, Well, here you see that the time to stand measurement was used, and it seemed like there was a remarkable gain, especially as compared to the control cohort that Elena mentioned before. So some more seconds seemed to have been gained thanks to the drug. And this is about safety during the extension study. So once again, good results. No severe adverse effects, at least related to the drug. And that is my last slide about NS-Pharma commitment to DMD. Actually, they are considering in their pipeline some preclinical trials. Actually, two have already moved on to their clinical stage for other exons. And let me conclude with the Capricorn molecule. It's a drug able to reduce the downstream effects of a lack of dystrophin, basically inflammation and apoptosis. Thank you very much.
4 minuti. Anzi, sono stati in 20 minuti.
Allora, grazie a tutti gli oratori. Iniziamo con un po' di ritardo la parte di domande e risposte.
And now, the Q&A session. So the representatives of the companies are kindly requested to join us here. Madeleine from Roche, Paolo from NS-Pharma, Silvano Berinoli for Santera, Riccardo Ena for PTC, and Rachel for Sarepta. Thank you for being here. Would like to thank the speakers, of course, for their clear presentations. And I have an announcement to make because we've run a bit late, which was good anyway, because there was a lot to get information about, and I know that you were all waiting for that. Therefore, the session, the parallel session on emergencies will start at 11. So that you'll have the chance also to be present at this Q&A session. So let us start with that. If you want to ask your questions, you can just raise your hand, and you'll get Ilaria and Emanuela, who will get to you with a microphone. A couple of remarks, if you allow me. Actually, I think that we as a community should always keep in mind that luckily enough, there are so many drugs coming up. And as the presenters said, these are treatments that may actually make the disease progression slower. And this is of paramount importance, but we must always keep that in mind, and always keep in mind that this can be achieved through many products, through many drugs. Let me also stress at this stage that Parent Project as an association is, eager to help. I mean, we've heard about some clinical trials now being started, hence the relevance of, for example, organizing webinars to tell the community about this. and therefore we are ready, to help. And one more thing I'd like to stress, I mainly gathered this from yesterday's session about some clinical trials that may also have side effects that could be more or less relevant. Now, when a family decide to include their son in a clinical trial, they commit, and remarkably so. This has many rebounds on the family's life, but also on, the staff of the site, as Professor Mercuri said. Actually, the staff at each site where a clinical trial takes place has very important responsibilities. Therefore, please remember that our counseling center is there. Our counseling centers throughout Italy are there for you to get some help from, to get the right support.
Vissuta nel miglior modo possibile. Detto questo, partiamo con le domande, quindi se ce ne sono dal vivo, Ilaria sì, vero? Ok, ecco.
Buongiorno. Si sente?
Good morning. Good morning. My question is to Dr. Bettica. Is there any evidence about Givinostat being used with exon skipping or gene therapy treatments? And once approval arises, do you think that Givinostat will be available to children for whom gene therapies or exon skipping therapies have already been approved or started?
Chiedo al server se ci accende il microfono che è sul palco.
Pronto? Ecco.
Ok.
Allora, riguardo alla prima domanda.
As for the first question, in the studies carried out so far, they only use Givinostat as an add-on to corticosteroids, so in combination with other types of drugs used in DMD, well, we don't have anything like that. As for the final use, when hopefully Givinostat is going to be approved, that is something we can say nothing about, because the indications, the use, will be regulated by the information in the drug, and that is defined by FDA regulatory bodies, FDA in the United States and EMA in Europe. Preclinical evidence of possible combinations? No, we don't have any preclinical evidence. In general terms, as to the mechanism of action, they are two completely different mechanisms of action, so they may be combined possibly, but we have no data on that at the moment. Good morning. The Translarna case. Well, first of all, I'd like to thank all of you, the Parent Project Association, first of all, and the clinicians that are truly helping us, LAPTC Therapeutics, because I hope they can support us as long as possible. My son takes Translarna. My son, not only my son, so if there is someone else here using Translarna, let's get together, because in my opinion, there is still something that can be done. Do we still have some hopes? I've seen some data that, in my opinion, are pretty good. So I'm asking you, is there the possibility somehow to stop this decision? My son is 6 years of age, but he can jump, and the treatment was started in October. So I'm very much motivated to ask for this drug to be continued till the end. So we really ask you to help us out, and thank you for what you have done and you are doing. You mentioned drugs. There are great hopes. There are many drugs that are coming along, and it is wonderful. But let's also remember those who are already there that work, maybe not work as well for everyone, but they work. We should not abandon them because they are a great hope. Thank you. Well, we are in a very special situation. CHMP defined twice the therapeutical index of Translarna, not in line with the expectations. You have listened to the presentations today, Professor Pegoraro, by analyzing the data in the correct way, but with a different method, with a different attention, the result would have been different. But we have another opportunity. This is a sort of political opportunity. You know, I'll tell you the story. After the last opinion of CSP, this opinion must be adopted by the European Commission. And I must say that all those that represent you, I'm speaking of patients' associations, the doctors who have been following you over the years, they have really created a great attention by politics. So in Italy, both in Italy and in Europe, there is a great attention at the political level. So the game might be simple. I mean, we should have 4 countries that have an important vote, because the vote depends upon the population they represent. Let's say Italy, certainly, Germany, and maybe Poland or Lithuania. I mean, 4 countries. If they vote in favor, I mean, rather, they vote not to adopt the CSP decision and so sort of send back the decision to CSP. At that point, Professor Mercuri and the whole team that belongs to that incredible network we have in Italy. Italy is a benchmark as far as the management of this drug is concerned. The results are exceptional. These are data that the network is very well aware of. With those data, we would like to be called by the CHMP to rediscuss it all, and there are possibilities of maintaining the drug available for therapy, at the same time giving them the possibility of taking a more balanced decision. We don't have a miraculous drug, but we have a drug that slows down the progression of the disease. And if all that is happening today in the world from the viewpoint of gene therapy may be a bridge, so to speak, we have also other therapies. We have a gene therapy, and we know that when it works, it changes patients' life. So we try to maintain it on the market. It is not a matter of money. I say that very clearly, because if the therapeutical value is recognized, even very small, and then IFA tells us, well, we pay for this drug €1, well, the point is keeping it on the market. If it is taken away from the market, they would be telling us we are marketing water. And this is not true. I mean, it's not water. It is a drug that gives results, not miraculous results, but children get more time. We have been speaking about time a lot. Well, we must lengthen the studies because the evidence appears much later. And the other time is the time that the children earn in terms of quality of life. And that is relevant, isn't it? Professor Mercuri, I wanted to reassure this lady. We are doing a lot together with Parent Project, but also with other associations of rare diseases, with the Greenwich Network. All the clinicians signed a document, and families are represented as well. So apart from the movement we can organize, in my opinion, the crucial moment, well, we cannot say to CSP, well, you're wrong because your boy is still jumping. We must answer with scientific data. The registry was not taken into account because the statistical P was not good, and they said that the studies have failed, whereas the registry demonstrated a long-term efficacy. We earn 2 points, 30 meters, but we must understand what it means after 4 to 5 years. If we put together all these small things we are earning, we slow down the loss of ambulation. In Italy, the registry was not taken into account because at the international level, not all countries inserted all the data. Some put only 20% of the children treated in that country. And so Europe thought, well, they are including only those where the drug worked. In Italy, we have 98% of the treated children that are included in the registry, and our network for years has been studying the natural history, so we can demonstrate that our physical therapists carried out the training and all. We're going to submit this data together with the families and the other associations, because if we keep sending isolated messages, just 10 families or just a group of clinicians where they are not significant. But if we send a large message, the the Wind, Parent Project, a number of associations, we are all together signing this document. We hope that they listen to us because we are referring to scientific data, not emotional data. We cannot simply say the lady there wants this therapy to go on. We need scientific data to convince them. Filippo wants to take the floor. Three things I'd like to say. First of all, to Elena, the lady who has just spoken. She said, well, Alice, sorry, I got the name wrong. Let's get together, and if there are other parents who have the same problem, let's work together. We are already together. The reason why we are here is because Parent Project has always worked for each and every one of us, because I myself, I am in the same situation. So sometimes when I hear these things, for me it's like a stab in the heart, because we don't want to abandon anyone. We are supporting all of you. My son has never taken Ataluren, but since the very first day after that decision was taken, I sort of got up and said, we cannot keep quiet. We must do something about it. We must manage to demonstrate something about this drug. And then there are ways to do these things. Well, it's simply because we have been working over that for 30 years. And we know very well that if we want to obtain results, we must plan a strategy. We cannot simply be emotional. You cannot, set fire in front of the European Parliament. No, we must rationalize, organize the reactions so that they are stronger. And that is why sometimes, this thing of saying you and us is terrible. That kills me, because when you say you, I am a parent exactly as you are, because if you say that, it would mean that our mission has not succeeded. It's always us, even if our children take different drugs. So it's we, always, all the time. And then we must channel all the reactions through the association, because each and every one of you can have a splendid idea. If you share that idea, we all become stronger, because if you stay on your own, you get nowhere. When Parent Project started in the US, and then when it was also moved, so to speak, to Italy, it was a rational approach. If I had wanted to do something on my own, I would have failed. And that is why we are here all together in this room and in the other rooms, and all those who are supporting us, because there is a piece of each and every one of us in this story. None of us by himself or herself can do anything. And this is, I take this opportunity to remind this to you all. Please do not think that you can do something on your own, because even if you are the best in the world, you'll never succeed. There are people. We managed to limit the fragmentation of the association, which was not the case in the US. In the US, there are at least 50 groups of DMD in the States, because in the States there are also economic situations that are very different. There are extremely rich families that, thanks to this power, thought they could solve the problem on their own, but they failed. Coalitions are the only situation. A small company cannot get the approval of a drug if it doesn't join forces with existing networks. So this really comes from my heart. This is something I'm very keen on. And I take this opportunity to remind you what we have been doing. We are preparing a letter addressed to the European Commission. And this initiative is not only an Italian initiative, because we are considering only what we are doing here at this very moment. We'll be sending this letter to all our partners. We have 25 associations who signed the first document we sent before Christmas, and they also participated in the Buy Some Time initiative. And as we are Italians, okay, the Italian data are excellent, but if Italians stay on their own, we won't win this battle in Europe. We must get the support of other countries. We must have as many signatories as possible for this communication, for this document, because by doing that, only by doing that, it becomes an important message for the European Commission. We cannot say that CSP understands absolutely nothing and we want to go to ignore them. No, this is not the point. There are problems demonstrating that these drugs work. This is not the first time this happens. It happened with Debenone. Debenone was a drug that had been studied for 20 years, and the drug is not studied for 20 years if it doesn't work, because that takes money, effort, clinicians carry out trials. So my suspicion vis-à-vis Debenone, I cannot say that it worked, because of course the European Commission said it didn't, but maybe that was one of the weapons we might use, we might have used together with everything else. I'm fully convinced that we lost an aid we might have had from Debenone, and now we risk losing also the second. But whereas Debenone is still on the market, so it is still possible to go and buy it, Translarna won't have the authorization for marketing the product. So it is going to be cancelled. It's going to be erased completely. And that is why we must try and be perfectly united all together to send an important message. For patients, it is, we are not sure that this drug is to be thrown in the dustbin. And I don't think the European Commission is certain about it either, because now we have the burden of proof. We must demonstrate that the drug works. If the word were turned upside down and they were to demonstrate that this drug does not work, if we ask them the same studies just the other way around, they wouldn't be able to demonstrate that it doesn't work. And there is another initiative we should be working on, a twofold work. So we must sit together around a table with FDA and EMA, so the international regulatory bodies, to decide that we cannot evaluate these drugs with principles that had been set for other types of therapies, because I mean, these won't be approved, and those who come after these first ones won't be approved either. And so when a drug for rare diseases, we can restrict the number of rare diseases with few patients, when that is approved in any nation within FDA or EMA, well, automatically it can be temporarily approved also by the other agencies for limited period of time, so that you have more data and you have a better possibility of deciding whether these therapeutical possibilities may become drugs for all. And so we must work for that in the future, whether we win the Translarna battle or not. We can do whatever we can, and there is a result that in the end we must accept, whatever it is. Of course, we hope they say yes, but if they say no, we must accept the result and survive, because for families it is impossible to think that there is just one tool, one weapon. This is important. But even if the decision was to be no, well, we must go on fighting, and we must find other opportunities to get more years and delay what's happening to our children. We are always all together. Thank you.
Grazie Filippo. Un'altra domanda la vedo laggiù in fondo.
Another question? Good morning. The topic has already been dealt with by Professor Mercuri. Maybe I missed something. The Givinostat trial for non-ambulant boys has already the inclusion and exclusion criteria set, or they are still being assessed? And a very rapid question, and this question is for all of you, all the experts. If the boys were to take Vamorolone, since it was approved, and we hope that it will complete the approval very rapidly, it is considered as another steroids, so it will become the gold standard, or to be associated with new therapies, or if the new therapies are approved, Vamorolone is to be considered an associated therapy, so that it might be difficult to use them simultaneously. I start with a question on Givinostat. The study has started. The investigator meeting was held a week ago, and the inclusion and exclusion criteria are on clinicaltrial.gov. I mentioned the most important ones: non-ambulant children, age between 9 and less than 18, treatment with steroids, stable with steroid treatment, and there are some criteria linked to upper limbs function. But on clinicaltrials.gov you find the details. At present, the centers are not listed in this website, clinicaltrial.gov, but the centers will be included very soon. We have time. Sorry. As for the question on Vamorolone as the new gold standard, of course, that is what we hope for. And so for the benefit of the community and the patients, drugs that have the same efficacy but with reduced side effects, this is so obvious that we are not even considering whether the regulators understand that or not. But still the problem is there, because as we said, in these assessments, what is judged first is the efficacy. Now we are changing the paradigm. Efficacy, of course, is essential because otherwise we wouldn't talk about drugs if drugs are not effective. But we must consider the reduction of side effects. And for the boys who have this disease, avoiding a fracture, for example, is something of paramount importance. So our expectation is that Vamorolone will become the gold standard, and certainly will also have studies that will consider Vamorolone one of the drugs to be considered as a backbone therapy. One final question. It is a very beautiful session. We would like to have more time to answer all the questions, but unfortunately we don't have it.
Diciamo, per WhatsApp abbiamo selezionato.
So, one question via WhatsApp from the Sarepta Roche gene therapy. What about its evaluation stage within the European agency? When can it be approved? When can it be made available in Italy? And considering how expensive such therapies are, will it be particularly difficult for us to find a financial covering?
Does it work? Yes, it does. Thank you very much for this very important question. And of course, I'm giving response on behalf of Sarepta and Roche, the partners. So it's with regard to Europe. So Roche is really in close collaboration with EMA, having already meetings setting up and discussing all the data. We aim to submit as soon as possible. And of course, you know, then it takes some time, review time. So hopefully, yeah, anytime next year, towards the end of the next year, beginning of 26, we will have a result from EMA. Now, when it comes, of course, with regard to Italy, of course, once we have EMA, hopefully a positive decision, that applies also for Italy, but then you have to go through IFA and get the price. Now here, I can't actually tell you about the price. Also here, we are early on in discussion with all the HTA bodies, you know, to make sure they understand the totality of the data and the benefit the drug can bring or might bring to the patients. And of course, by the end, find a solution also on the price. But I have no details yet.
Grazie mille. Allora, mi dispiace.
Thank you. Well, I'm very sorry. Hopefully your questions will be sent via email to our speakers. Thank you very much. We'd like to thank the speakers, the companies. Thank you, each one of you. Thanks for being so willing to answer the questions. And before starting next questions, let me remind you that you should stay until the very end. Your big surprise is coming up. Thank you.
Allora, un momento di attenzione, adesso abbiamo una tavola rotonda sulla diagnosi genetica preimpianto. Intanto
So now we're going to have a round table on PGT, and emergencies will be tackled at Sala Bergamo.
Cioè, questo è un criterio, io l'avevo detto, Buongiorno, ciao. Buongiorno, dottore.
Posso avere la... Prima di cominciare la tavola rotonda, la nostra...
Before starting our round table, there's a message for you from one of our speakers. Thank you. Thank you all. Please take your seat so we can start. We are running a bit late, actually. But here is my message. It's about this campaign called in Italian CAD Anch'io. It's to promote the DMD counseling centers. Unfortunately, we do not have one of them per each Italian region, which is a problem also for us as clinicians, because counseling centers account for a very important space for families to get in touch with us clinicians, mainly for the PGD. We have precisely through the counseling centers had the chance to get in touch with many families, because last year we gave a very short presentation, further to which many people tried to get in touch with us, which could be the case precisely thanks to the various counseling centers. So please help this campaign through a donation. You can with a simple click, you can actually donate, thereby helping counseling centers cover, every single community in Italy. Thank you.
Allora, chiederei magari a chi...
So, if those who want to keep talking about the previous the topics in the previous session are kindly requested to leave the room. Okay, so we're going to start our round table. This is a topic we're very fond of, both in scientific terms and in terms of the counseling of our counseling centers. I represent the scientific part. Emanuela represents the counseling centers. Actually, we thought we should have this round table because families have always told us that they felt like it was needed, and in the meantime, we have in these past few years managed to give more and more information about the different pregnancy tests, especially as for an ART and an embryo gene analysis. But some of these aspects were particularly difficult for us to cope with, also considering the difference, the various differences in the Italian regions. But then we got in touch with Dr. Andrea Gallinelli. He's a gynecologist from Ferrara, northern Italy, and this is precisely, in vitro fertilization is precisely what he deals with, and he deals together with his colleague also with gene analysis, and they are in cooperation also with Marina Forte, who deals with the reproduction techniques here in Rome. So we have started cooperating, and we thought it would be very relevant for us to have a session like this, also considering that there are many mothers or sisters who are carriers, but who may be interested in learning more about possible pregnancies. And actually, we got some requests about this from, however, only 12 persons, 12 women, which clearly shows a gap between what we know we can do and what families know it can be done. Therefore, we need to inform families, to educate them, which is what we're going to do now through this round session. But we're also going to have a special section dealing with this issue. An event will take place in Naples next April the 20th. You'll read more about this in the leaflets on the tables. And our future cooperation will precisely orbit around this. So PGD in the field of DMD. So now Daniela Zuccarello has the floor.
Grazie Ilaria. Grazie. Vi chiedo la presentazione. Ok. Buongiorno a tutti, io sono un medico genetista, mi occupo insieme agli altri colleghi appunto di
Good morning. I'm a general practitioner, and I sometimes find myself in suggesting as many families as possible should know more about how to deal with pregnancies, and some pregnancies in particular. Now, as I'm sure you know, DMD in genetic terms entails carrying women, although it's basically males that get the disease. So there are many people who are healthy carriers of DMD without knowing it, possibly because there's never been a case in their own family. So we believe that in the general population, there is a rate of them that is much higher than we seem to know based on the studies that are only carried out once a given case in the family has arisen. Now, PGT is basically a prenatal diagnosis, villocentesis and amniocentesis. However, they also entail that once the sick fetus has been identified, there is a termination of pregnancy. And this is precisely what we want to avoid. We don't want any woman to be forced into a TOP at the very end, so to speak. So we want this to be framed within a much earlier phase. So the embryo that has not inherited the gene problem should be identified before pregnancy, in a way. I mean, before pregnancy goes on. So, PGT, pre-implantation genetic test. This is an acronym we should keep in mind. Well, the PGT for DMD is the so-called PGT-M, so the one that regards monogenic diseases. Now, we've been working for a long time on an embryo in a very early phase, that is on day 3 with 8 cells. And actually, the in vitro embryo harvesting techniques have improved, and remarkably so. So we now have a gold standard, the blastocyst, that is an embryo on the 5th or 6th day of its life. So that's quite a well-organized structure obtained through in vitro cultures. Now, what do we do based basically. What is the technique about? So a small hole is made with a laser on the embryo, and then we use this very fine device whereby a peripheral part of the embryo cells is sucked, and with the laser, as you can see, we try to best divide the cell junctions so as to obtain the relevant material that is then sent to the genetics lab, further to which we carry out our DMD or other diseases molecular analysis. Now, what do we take from the embryo? Well, a very specific part, namely the trophoblast cells, those that will be a part of the placenta. So we'll never touch the one that will become the child, the baby, so to speak. The orange part is never touched. So what we're basically doing is a villosynthesis, but only 11 weeks earlier, because we use the same cells. So the PGT pathway always starts with gene counseling, and then it is placed within an ART approach. For DMD, for example, a preparatory phase is of paramount importance. It is a customized one because, alterations change from family to family, and then the actual pathway can be started. But I won't go into that because Gallinelli will do so. So anyway, once that is started, once that has been started, the frozen embryo cells are sent to the relevant lab, and when we get the results, we'll send them to the ART center, and if the result is positive, hopefully the baby will be born. Now, of course, there are some problems that arise when it comes to DMD, especially because we may sometimes have de novo deletions, for example, and in that case, we need, if that is possible, especially with deletions, we possibly need two subjects from the same family, for example, the DMD boy and the she carrier, so to speak. So then a setup phase starts just to make sure that PGD can actually occur and make all the data properly visible. This is an example of this setup whereby we can identify the specific deletion, in this case the 45-55 deletion, but we can also identify the DNA bits that normally surround dystrophin, whereby the diagnosis can become much more robust with a possible sensitivity rate of almost 100%. So then the biopsy and the analysis, basically, of the biopsy is done by the relevant lab. We'll see whether the deleted X chromosome has been inherited, in which case we see within each embryo the typical chromosome-related diseases that are considered in the initial phase of a pregnancy. So we can have a complete file regarding the woman in question. Now, this is carried out in many centers in Italy. According to the latest data, some 70 sites were present in Italy where this technique is actually employed, but too many people still know nothing about this, which is, a pity, because second pregnancies might come further to that. We now have a PGT unit in Padua, where we work in close cooperation with other state hospitals, Trento, Ferrara, with Dr. Gallinelli and other ones, so as to be in a network, thereby allowing patients to be sent to the one site that is the closest to their to where they live, because they must go to this site quite often. A few years ago, with Andrea Gallinelli, we also created a non-profit association, NIDO, NIDO. Here it's the website which provides families with some educational material. You can click on the region you're interested in, and you'll find the center that is the closest to where you live for your PGT. Last year, we got some funding for the setting up of the national network of the state-owned centers, PGT centers. We only started that last September out of bureaucracy, but in the next 2 years, we'll hopefully have an actual network, an actual national network, because right now, for example, in southern Italy, there is no state-owned center, so patients are forced into moving north, so to speak. And here is also the website of another relevant site. And then we're also involved in education. Well, we talk, of course, to families, to patients, but we also try to train the trainers. We try to let all doctors know about this. We hold a national conference every year. This year it will take place. It will be held in Padua next June the 21st, and patients and associations are invited, of course. So we really try to do our best to widespread to widespread the news about this technique. As Ilaria said before, we work with a center that has public financing in Tuscany. Its name is Demetra, and we are also in close cooperation with them, so that we choose every year a given association. This year, the Parent Project Association has been chosen. We'll meet in Naples in April. These are free meetings, I might add. All possible questions can be asked at that time to the doctors that precisely deal with PGDs. Thank you very much. In case you want to call me, here is how you can do it.
Grazie Daniela per questo.
Thank you for this very precise information, very clear, very simple. This is precisely what we need, as well as the possibility for all carrier women to have access to this method. And now we give the floor to Gallinelli. Good morning. I wish to thank Ilaria and the conference organizers. Thank you for inviting me this year. It is a conference that teaches me far more things than what I can teach you. I'm a gynecologist, and of course, on some things, I'm going to repeat some of the things that Daniela has already mentioned.
Fertilità di coppia è molto diffusa nel mondo. Non vi sto a dare dati.
Couple infertility is quite widespread in the world. Don't think I'm being too general, but pre-implant diagnosis, pre-implantation genetic diagnosis must be done with the ultrasound view. There are some techniques for assisted reproduction. We have an ovarian reproduction that in a couple of weeks will produce some follicles, as is the case in nature. And then you have the pickup. There is taking of the oocytes. The person sleeps for about 20 minutes. Here you see the tip of the needle inside the first follicle. And then, as Daniela has already mentioned, there are the more specifically biological techniques. Biologists with the ICSI, so the sperm, it is an ICSI, and so you put the sperm cell in each egg cell obtained, and then you have a certain number of embryos being produced. And after a few days, we have the transfer of the embryo in the uterus. Normally, we do it after 6 or 7 days, so at the stage of blastocysts. We have a problem all over the world that doesn't concern DMD only, but it concerns the age of women. Women tend to be older, let's say 38 something, and in Italy and in Ferrara province 39 years of age. So very high percentage of women, of couples that want a first pregnancy above age 40. Which means that as you grow older, women's fertility, for the fertility part, maternal age and fertility patterns, so some cells are never replaced. They tend to age constantly. So maternal infertility it becomes very high. Why is that so? And you see there the percentage of aneuploidies, and here that is expressed by the lines going upward. When you start being around 44, 42, 43, 45, the percentages go well beyond 80%, which means that most of those oocytes that we harvest are have an aneuploidy. We are not speaking of DMD alterations. No, they are alterations concerning chromosomes, pieces of chromosomes. I'm not going to repeat things that you know already. And the first observation might be, very well, isn't that enough? Isn't that enough to look at the blastocysts under the microscope to decide whether it can be implanted in a genetically correct way? And the answer is no, because also blastocysts that may look excellent, only a bit more than 50% is truly euploid. Of course, the age range is between 38 upwards. Sorry, is from 38 upwards. What help? The help may come from PGT, the pre-implant diagnosis. And the first step is the biopsy. Mrs. Zuccarello has already shown that. So second clip number 2, where I, repeat the same things. And here it is again. There is this holding, blocking the blastocysts, 5-6 days, and there is one sphere with about 60 cells, 60 blastomeres, and then there is this laser ray that creates a small hole on the external part. And with the slightly different methods, we harvest some cells that will be given to the genetic lab for the analysis. You may have different types of analysis, monosomic alterations, structural alterations, PGT-NSR, or aneuploidy, PGT-A. the PGT M and S are transferred to the regional system, whereas the PGTA is never paid for by an Italian region. They are to be paid by the couple. In the state sector, the figures are not very high, whereas in the private sector, of course, they are far more expensive. There are about 7 centers of assisted reproduction in Italy that carry out this pre-implant analysis, the PGT, but not many of these centers are truly well prepared. And I just make an example. In my profession, if I carry out surgery, a given type of surgery twice a year, I want to have the necessary clinical competence to propose that. If it is a type of surgery that I carry out every day or more than once a day, I will have a clinical competence that is sufficient and necessary in a way. And that goes also, this is true also here in our hospital. In 2023, we carried out about 300 biopsies. Most of them were about PGT, aneuploidy, trisomy, and so on, polyploidy, and a smaller percentage concerns specific alteration, PGT-SR, PGT-M, PGT-A. But we have a good standard. I'm not going to give you all the details, but the first doubt is, but is it invasive, so it is detrimental? It isn't. From the slide, it is clear. On the left, you have the numbers for without biopsy and with biopsy. There is no statistical difference on the implantation rate. Why? It depends upon the evolution of the technique itself. When I started in 1996. There were still maybe some dinosaurs on the earth. And we started at 6 in the morning and we would finish at 23, and we checked a couple of, maximum a couple of chromosomes. Now with NGS and other systems that I don't think you would be interested in detail. And with the laser, we have this situation of no damage due to the biopsy, because the biopsy is carried out in the trophic derma, not in the inner mass, that is the part where the embryo originates. So for whom is PGTA, aneuploidy, and all those who ask for it? So this type of population, advanced maternal age, aneuploidy unknown, failures, and also miscarriages, and severe male infertility. What are the prerequisites? Skill, adequate instruments, and the possibility having a cryoconservation lab, because obviously we'll have to cryoconserve blastocysts. Sometimes we have 2 blastocysts. One is transferred and the other is cryopreserved for other attempts, because, of course, we don't have the immediate certainty of starting a pregnancy, just transferring 1 blastocyst. These are very important papers of the recent past. The advantages of PGT, generally speaking, apart from what may be of your interest, of course, there you're interested in Becker and Duchenne, but we have very clear results. The international literature confirms all that. There is there is an increase in the rates of cumulative pregnancies. No, but there is a reduction of the time to pregnancy. So the time necessary to obtain a pregnancy In Italy, just for the infertility diagnosis, it takes 2 years, and then there are the waiting lists, especially in the state sector. Of course, a reduction in the time of pregnancy is essential, apart from being able to transfer embryos that have an appropriate chromosome setup. And what are the disadvantages of PGT? PGT is not paid for by the national health system. We are working on that, but for the next few years, we don't have great hopes of getting it free of charge. And so this implies further costs for users, even though, as I said, in state department, in public department, the costs are very limited. In our center in Emilia-Romagna, a cycle of PGT, and I repeated, it is about 1,200 euro. In a private structure, the costs are tenfold higher, so it's about 10,000 euro. That is why it's so important to have networks and, knowing what are the public structures where you paid less. And there is something else from, south of Rome, there are no public centers. And so the people ask for permission to come to us. Some regions authorize that, others don't. We have had problems from Tuscany, Liguria, Piedmont, Veneto, Marche, and so on and so forth, whereas Calabria, Sicily, Sardinia, Puglia have very big difficulties in giving this authorization. 95% of cases, they won't give the authorization. There are a number of reasons for that, but that, of course, that determines a very clear effect. Of course, you can improve. Everything can be improved. As I send the PGD. The PGT implies skills, adequate tools, so constant upgrading of the equipment. And the future, thanks also to artificial intelligence, is trying to be even less invasive. With the aspiration of just the microsuction of the blastocelic fluid before vitrification that increases survival and pregnancy. So you don't take a blastome, or with the culture medium where there are traces of fetal DNA, you can amplify that and without touching the embryo. It is very safe, but of course improvement is always possible. The blastocele aspiration are still on the go. There is really work in progress. Only in 1/3 of the treated cases they show specificity that's such as to give absolutely safe result. In clinical practice, you cannot consider that 30% of cases shows that the technique is routine. So we are waiting for progress in the future, but the initial bases are promising, and you know what it means, because we have been speaking of promising basis starting point. Thank you for your attention. Now I ask half a second, a couple of minutes, to send my first clip, to show my first clip, clip 1, showing you our center, because speaking in theory is one thing, but if you can have a look at the center, probably that's better. It is a bit special at the national level. This is not a commercial, certainly, so we do just that. An assisted reproduction center normally is in obstetric clinic with a waste of money, capital, and whereas we have the possibility of working only in this area of assisted reproduction. We work very well. We limit waiting lists. This is something we do, and devoting ourselves exclusively to this aspect. This is us, the first part, the diagnostic part. And we meet the couple with a couple of interviews. In the second interview, we can give the therapy. We collect informed consent, and we do the first attempt. The micromanipulator, they take the sperm to be injected. This is our cryobank canister UR. And of course, we have an increasing number of people coming to our center, so people tend to come more and more. This is our surgery. This is our hospital from the drone. And the thing that is more disturbing for us is that many couples ask, but they have great difficulties to obtain the authorization to come to us or also to us. Thank you.
Grazie Andrea. Devo dire che io
Thank you, Andrea. I had the opportunity to participate in the meetings on assisted reproduction where those you organize, and I've really realized that we are really in good hands. There is a team of experts and a network that works on that with great passion. They keep improving the technique and the accessibility from all viewpoints, so the results are there. And now I give the floor to Emanuela. Good morning. Well, the counseling center and the scientific office are collecting requests for information by carriers, women carriers who want to have a second baby, avoiding any reproductive risk. As Ilaria said, this is one of the ways to provide specific information, and another way is that of sharing experiences in order to favor the spreading of information. And that is why we decided we want to give the floor to parents and to try and collect as much evidence as possible. We have prepared a questionnaire that we sent to all the couples that did something similar. And now I will share with you the data. Of course, there are very few couples that today are aware, first of all, of this possibility, and so that get in touch with us as association. But this information may be significant for those who want to do something similar. From the questionnaire, we have both mothers who decide to have a second or a third baby, but also sisters or other women carriers that are present in the family, but also dads, maybe dads that have not a genetic problem, but they have the emotional, but they live the emotional part of the thing. I mean, of wanting to have a baby, and there is so this. They don't want to have a reproduction risk. They want to have a baby that hasn't got the disease, but they don't want to give up the idea of starting a pregnancy, but limiting or avoiding the possibility of having a termination of pregnancy. So the sample at the moment of filling up the questionnaire, where the average age was 39. So here again we are between 36 and 44. They came from the center and the north of Italy. We have had some families who asked for information also in the south, but due to the difficulties that have just been mentioned, that is a limit. And besides, most couples only carried out one attempt and others from 2 to 5 attempts. But among the couples who just tried once, some of these couples had already decided from the start to try just once. And I asked them we asked them what were the prevailing obstacles they had to face. The first obstacle is the economic one, even though most of the sample did this assisted reproduction course within the national health system, and there was a smaller percentage who went to the private sector. Second obstacle, the ethical obstacle. So the question is the ethical issue. And last but not least, also the tiredness and the stress. So we also wanted to investigate the most troublesome moments in this route. And first and foremost is looking for information. That is why we have organized this session today. So information at different levels that in the end will lead to a choice, doubts, uncertainties, and then really this fatigue that is present also in the following phases, waiting for the result. The whole pregnancy is lived, of course, with some concern, some apprehension. And then in the final parts of the questionnaire, we asked if they had any psychological support, and a good number of people had had at least a first interview in the center, and then others also had other interviews during this procedure. First of all, that is important to face doubts, uncertainties, many choices, and also further phases. For example, it is very difficult in the centers of the National Health Service, where you have to also to undergo a number of checks, of visits, and then the waiting for the result. And when it is a negative result, of course, you have also to live with your failure and decide whether you want to try again or stop. Of course, we asked a number of questions, and also being able to know where to collect information, both with us, the counseling center and the scientific office. So some quotes. A mom tells us it is a light for the future. All should have the possibility of using this tool. Another mom, feeling alone and lost with very little information and not knowing where to go affects you negatively within an experience that is already very complex. Said that due to the failure of our attempt, the next days were very challenging, both psychologically and physically. Then we re-emerged. So from the voices of the couples that do that will show us how difficult it is, but it is a possibility. It is something you can do, but you must have a support, help first in looking for information, and then all the following phases. So this is what comes from the counseling center. But to give you more details of the psychological aspects for couples who decide to follow this route of assisted reproduction and PGT, well, first of all, I give the floor to this colleague of ours working in Rome. Thank you, Manuela. Thank you for the introduction. And I wish to thank Ilaria and the Scientific Committee for the invitation. It's a great pleasure to be here with you. I'd like to start from what emerged from the questionnaire, sort of this qualitative analysis of the answers, because this is the reality of the experience of couples that, due to the high reproductive risks, decide to go for assisted reproduction with the PGT. And I believe that the emotional part, as reported in the answers to the questionnaire, the emotional part that is something I deal with in my profession, well, that has many aspects. Well, why? Because before any reproductive choice, there are personal histories and personal narratives that are made up of great suffering, sometimes traumatic experiences. So the reproductive choice is to be considered within a narrative, and it is also determined by it. Consider the cases where the couple decides to give up and not to become parents because they are not ready to face the reproductive risk, or because they have traumatic experiences in the background. The alternative is conceiving spontaneous conception, but we know that this choice means also running a risk for the couple. So after the prenatal diagnosis, the couple may be informed of fetus that has the disease, and this communication is extremely traumatic. So there is a sort of, you may also have a diagnosis of stress, post-traumatic stress disorder, so rage, despair, sleep disturbances, food disorders, eating disorders, and so on. And the couple, after such a diagnosis, then the couple must decide, must choose, making an extremely difficult choice for the couple, deciding whether to have a termination of pregnancy or go on. When there is a termination of pregnancy, the psychological consequences are present. And so it is possible to develop typical psychological sciences, I mean, of this bereavement. It is a physiological bereavement that may be solved within 12 months, but there are cases where this bereavement may be complicated and you have more pervasive symptoms that may go on over time. Luckily, today we know that there is an alternative for couples that have a higher reproductive risk, that is this route of assisted reproduction with PGT. So this is an excellent opportunity for these couples, and the main motivation, the main reason for doing that is having a healthy child and avoiding a termination of pregnancy. And this is an opportunity, and this is a choice you can make, because the couple, in a way, acquires some control of the situation. So in that case, conception and pregnancies will not follow, let's say, a random destiny. So couples that have access to assisted reproduction usually have very high expectations. So you must prepare them also from the psychological viewpoint to explain what is this, what sort of experience they are in for assisted reproduction with PGT, because it may be very stressful from the emotional viewpoint, and because it is a stepwise sort of thing, and between one step and the next, there is a lot of waiting implied. And if you have to wait, well, that creates anxiety. This is something unforeseeable, because there is nothing we can do to affect the result. And during assisted reproduction, the two critical phases of waiting are the moment when you wait for the results of the genetic diagnosis of PGT. So when the persons will be told how many healthy blastocysts are available for the transfer, and then waiting for the results of the pregnancy test, where of course you have no control whatsoever. The couple is in a passive situation. They can just wait. After the waiting, there is, of course, the result. And so the couple will discover what is the result of that step or the whole cycle of treatment. And there you must work on the general expectations. Usually the expectations are very high because, of course, you may have failure. And the couple, this is lived as a true failure, both personal failure, couple failure, or of parenthood as such. But the failure within assisted reproduction is a bit the rule. So we must become aware of that. People must become aware of that. And the only weapon is being able to try more than once when there is a good prognosis, trying with more cycles of treatment to optimize the possibilities of being successful. How do you feel? Well, the image that describes at best the emotional part is that of a roller coaster. So in the initial phases, people are very optimistic, they are positive, and then there are moments of great anxiety, moments where there is a really a collapse in the mood, and the reactions are absolutely typical. And so they and then after a while these problems are overcome. It is possible to face all that better if we concentrate on the present moment without projecting oneself in the future. So it is necessary to ask for the support of the people who are close to us, and trying to keeping the couple relationship stable, and not leaving just waiting for what we desire to happen, but try to enjoy whatever we have in our lives. Well, to make things more complicated, there is the possibility that the couples who decide in favor of assisted reproduction, not because of their infertility, but to reduce the reproductive risk, they, for example, the pickup oocytes or the monitoring for ovulation, they have may have a sort of reminder of traumatic memories that may be a traumatic moment for people who have had unpleasant experiences in the past. And there is the ethical aspect. In the literature as well, we have seen that couples judge positively this PGT because, of course, it doesn't select traits or the gender of the newborn, but a nobler objective, being able to evaluate the presence of the disease, having a healthy baby. And there is also the ethical dilemma of the destiny of the embryos that have the disease. These embryos have just one destiny. They are cryopreserved for a very long term, but it was reported that couples consider that far less demanding to think that they have these embryos with the disease kept there and cryopreserved rather than having a termination of pregnancy. So the psychological support, both in the decision-making phase when a reproductive choice is made, but also when you have the treatment and during the treatment, of course, that is a very important aspect to be taken into account. Thank you. And now, to give once again the floor to parents, I give the floor to Silvia Tozzi, who is the mother of Leonardo and Federico. Good morning. Sorry if I read, because otherwise I wouldn't be able to remember all I wanted to say. Well, when I have it. Okay.
Mio marito, Andrea, e
So the family is made up of Andrea, Leonardo, and Federico.
di essere in 5.
But we hope very soon to be a family of 5, so to have another child. And after the result of the genetic investigation, almost by chance, because we went there just for an orthopedic checkup for Leonardo's orthesis, they told us to check CPK. The CPK was very high, and so we go in for buying orthotics, and then we have this result. Suddenly, our life changed, and all our projects changed. We created a new timeline where everything would be different, and we ourselves wouldn't be the same any longer. It was like an earthquake, everything collapsing. But the basis on which this happened, well, those bases will never be destroyed. The solidarity between my husband and myself and the children enabled us to face everything together without ever avoiding moments of despair and moments of absolute lightness. Today I'm here with you to share a step that has other steps in the past and many more in the future. And what if we wanted to have other children? So we were sort of scared during the interviews at the day hospital, as if having to deal with Leonardo was already sufficient to having enough to do, and we sort of felt guilty in our desire to become parents once again. But the answer was very clear from the psychologist Manuela Giulitti, who has now become a friend of mine of the Parent Project Association. She said, what you feel is absolutely normal, is commendable, wanting to live that magic once again and making the children share these joys and many more. Life goes on. As for non-fertile couples or other cases where the genetic investigation, so where we have assisted reproduction, PGT, it is a very well-known technique. It is used, it is not, you are not sure of getting the results, even though the route is followed very carefully. The probability of success is about 50%. This is an aspect to be taken into account. You must think about it and understanding whether it is the appropriate moment, also the psychological and emotional level, and choosing, being in full awareness whether to start doing that. Of course, you can try again and again, but being truly ready enables you to keep the energy that is necessary to try again. So assisted reproduction is a great opportunity for us. We can give our children the possibility of having another baby boy or baby girl in a safe way. Having a new member in the family is a deep, deep desire, deep felt desire, because the more love Leonardo will have, the more his life will be full and happy. Special thanks to the Parent Project Association, who has given us information both at the practical level and in other ways. So first of all, knowing what structure is the best one, what is the expenditure. Initially, we started with a team of a Rome hospital who very superficially, after a number of questions during the interview with the anesthesiologist, defined me as not enrollable because I had a suspected hyperthemia, malignant hyperthemia, due to the high levels of the CPK and the fact that the structure was not ready to manage these cases. The values are due to the fact of being a healthy carrier of the X deletion and not to malignant hyperthemia. So we were faced with this refusal by the structure. Of course, that experience, together with the difficulty at finding clear and practical information at the other state hospitals, of course, that has sobered our enthusiasm. The only answers came from private clinics, but they were really too expensive for us. And because the reasons why you decide to have assisted reproduction and PGT, well, are very many and involve many couples. The state should guarantee the presence of a higher number of public structures for this treatment. It is unacceptable that in Rome there is just one public structure of this type, one state structure only, and it is so difficult to have access. And if you are not eligible, if you are eligible, you are put in a very long waiting list, at least 1 year. So the people must travel hundreds of kilometers and try and look elsewhere, and having to ask for an authorization to one's own local health authority just to have the state contribution also in some other region of Italy. After a few months, thanks to Parent Project, I got in touch with Mr. Gallinelli, who is responsible for the Assisted Reproduction Center in Ferrara. And even on the phone, he told us, he gave us all sorts of information, both on the technique of assisted reproduction as well as the bureaucratic and economic aspects. Well, we thought it over. We talked about it also with the children. Of course, our children are special, and we owe them much of our force. But the spontaneous reaction they had was the answer to any doubt. Leonardo, looking at his brother, said, well, we'll have a baby boy to look after. So after a few months, at the end of January, we went to Ferrara, this hospital, where Mr. Gallinelli was waiting for us. And with a brochure, he explained us what the assisted reproduction was about, speaking about the pharmacological therapy and also about PGT, timing and mode of inclusion. We are waiting for an answer from our local health authority, and we hope for the best. Thank you.
E adesso, insomma, abbiamo visto tutte le...
And now we have had all the presentations, and we have a lot of useful information. Today, this is really extremely important because we can share this information with whoever wants to have access to this information. Is there anyone wanting to ask questions? There are sisters, not only mothers, sisters who are, of course, getting to this, the time where they may want to have a baby.
Se non ci sono domande, la faccio io una domanda. Volevo sapere se...
Here's my question. Based on your experience, basically my question is to Doctors Gallinelli and Zuccarello. Do you sometimes suggest a heterologous technique should be used? And what about a PGD in cases of no special problems. Okay, so thank you for your question. First of all, a distinction should be made. If a PGD regards, is a PGDM, for example, as it goes with the DMD patients, that is one thing. Another thing is if it is a PGDA, well, here, in other words, there may be a close connection to oocytes and the woman's age. So that is another thing indeed. So say a woman is 40 years or older, well, can she transfer a blast, or can we get a blastocyst from her? Well, this can't possibly be a success story unless we consider that around 50%, so to speak. So I really feel like we should beware of those centers that release very, very high percentages here, very high rates. This has nothing to do with today's reality, I'm afraid. Whenever we talk, however, on much younger eggs that usually derive from a woman between 20 and 30 years of age with previous pregnancies, well, here, for example, engraftment may depend on a certain number of elements, of factors, including the uterus, for example, and this makes it all much better. So if there is a maternal age that in reproductive terms is older or oldish, well, then this can indeed be a good chance, because we have on a world scale some 70% rate of pregnancy probability, and these pregnancies might not need any PGD, not even a PGD-A, because the oocytes that are behind that are made up of eggs derived from a woman from 20 to 30 years of age. I often give a trivial example. I mean, 10 oocytes from a 22-year-old girl, 9 out of 10 are euploidic. Otherwise, we may have an aneuploidia, and if the woman is 42 years old, 8 out of 10 oocytes have aneuploidy, which says it all. And I'd like to add something. Today, ART, indeed any ARTs, are all safe. I mean, there may be risks, there may be problems, but they have basically been ruled out. And PGT is very safe too. However, we do not have 100% possibility for it to achieve good results. Plus, there are 2 psychologists working with us who help those couples that ask for that kind of help. And group therapies will probably be started soon, maybe twice a month. We're going to have such group meetings during which not, the single episodes, the single cases, rather, will be considered, will be tackled, but, the psychology behind them. Well, I often tell my patients, look, we don't have any real risks here, don't worry about possible, hormone problems. There's a psychological risk, though, and I'm saying this maybe in the wrong way, but it's a sort of a bereavement. If failure occurs, it's like a bereavement, and it may be very, very hard. So what I'm saying is that we've tried, for example, to reduce the number of times when we meet the patients, the women rather in question. So So there's a psychological interview at the beginning, one, of course, with us, another one with the biology unit, further to which the second time we meet is usually via telemedicine, unless the couple ask differently, of course, and then only two ultrasound tests are carried out before the pickup, and then there's the pickup time and the transfer later on, and so on and so forth. I mean, we can't really be any quicker than that, and this is also why well, actually, this is what we like doing because if everything's okay, within, say, 1.5 months, we can have our first attempt. Let me add something practical. We now know that, healthcare system in Italy is not national. It is regional. I'm sure that you as families know that only too well, which also goes, of course, for PGD and ART, which was not included in the list of the basic levels of care. As of last January the 1st, a new list of such standards was supposed to be published, but that will only happen next April the 1st, in which case we're going to have a new list also of the relevant prices, regarding possible aids, which you might be particularly interested in, and the rest, of course, because right now, the re-entry plan does not provide for locals to have, to go somewhere else, outside of their own region for ART, which is awful because it does not, it has nothing to do with human basic rights. So the essential standards, I might add, do include vilosynthesis or amniocentesis, but not ART, which is quite paradoxical. So anyway, PGD is not supposed to be included in the next list of essential standards of care, although apparently this will sooner or later be the case. We know that a dedicated committee is within the Italian Ministry of Health taking care of this list, whose first publication dates back to 17 years ago. So hopefully they will be a bit faster now. That's, of course, our hope, but that's how things are right now. The, say, most enlightened, so to speak, regions in Italy have actually released some, special regional decisions whereby these women can actually leave their own region to undergo ART in another region. And actually, there is a legal system behind that, a legal office that so far has been involved in the relevant litigations that they have won, all of them, I might add. So in case you're interested, please ask your questions. Go to the counseling center closest to where you live, or get in touch with us, because this is something that can indeed be extended to all families interested. Thank you. Who are interested. Good morning. Good afternoon, actually. The question is on behalf of a family. A few years ago, they underwent a heterologous ART with PGD, but a DMD baby boy was born. So what happened? This is the question. Well, that was not the only case. So, for the heterologous technique, the donors are screened for some genetic diseases as well as their general health conditions. This is a basic kind of screening that is carried out. We're talking about the heterologous technique, and unfortunately, DMD is not included here. It's not included in this screening, which is a pity because we ought to have some screening test lists that through a simple blood test may, allow for the identification of even rare diseases. This has been the case in the U.S. for the last 20 years or so. They are, it's a sort of a screening kit that is often given as a present to marrying couples, which is very good. It's as though they were, told that they might want to go into, as safe as possible pregnancy time. Have you ever been told anything like that? I'm sure this has never been the case. And by the way, this kind of a test, even if you go to a private clinic, will not will not cost more than 250 euros. And after all, it's not such a big, not too big money, so to speak. This should be extended to all the population where there are couples wishing to be involved in a pregnancy. This is very important. Just think of how much would be saved, how much money would be saved. Before COVID, I went to see my regional counselor to talk about three important diseases, such as SASM and other ones. And we realized that some 2 million euros every year could be saved just through these screening activities that might spare so many drug trials, not to mention the management of the sick baby. But they have, there are political issues there. Given a given government, even local government, might not want to take that up because, after all, they will leave the bucket, so to speak, for someone else to take care of. The bucket will not stop there, so to speak, and will be moved on to the next government. But that's too bad. I just left, and I thought that we were just speaking two different languages, me and the counselor. My name is Stefano. I am Federico's dad, and I also work for the health counselorship of the region of Sardinia. Actually, we did that kind of screening for ASM. And actually, Sardinia is one of the Italian regions where this is being done. Actually, it is not being done because of bureaucracy, not yet, but everything is in place for this to actually be done. That took quite a lot of money, I might add. So it would be interesting for us to know more about this kind of screening that you have mentioned, because after all, it could, be a list including all the relevant diseases. And if that cannot be achieved at a national level, well, we can try at a regional one. Cost-benefit ratio, shared between today and tomorrow. What does that mean? What does that mean? We are not building a bridge, which is very important, of course. But I mean, we are speaking here about something very different, which might be actually an all-embracing benefit. It might pave the way to an all-embracing benefit. For ASM, last year the funding was 150,000 euros. Well, hopefully this will, lead to a maximum of the benefits, so that we may have saved it all. But even if we just saved just a bit, well, that would be a lot too. Maybe if we, manage to allow just one single person to have a better quality of life, well, that would say that the money has been well spent. Thank you very much for mentioning ASM. That's a very interesting example. Because a drug for ASM was released a couple of years ago. Well, 1 million euros per one administration. Can you imagine that? And then, I tried to bring this up, but it's tragic. I mean, we must really fight every day for that not to happen. So thank you very much. Let's keep in touch. Let's keep in touch. Who knows? Maybe a national action might be taken, which could also include a DMD screening. Thank you very much.
Sì, direi che siamo già un po' in ritardo.
We are running a bit late. Therefore, we can close here. Thank you very much. Well, these are very helpful discussions when we certainly need to work, harder and harder. Thank you very much also for helping us, decide what to do. Would you like to say something, Emanuela? Well, parents say it all, really. But as Silvia said, that is truly an added value whereby to cope with the situation from a very different perspective. So thank you.
Mi sentite bene ora? Eccoci arrivati all'ultimo.
Well, this is the last session that will close this 21st International Conference on DMD and Becker. And of course, these are, of course, it's a very topical issue. It is a subject we absolutely wanted to include, and that with which we started working in January. Maybe not all of you know about it. In January, we had 3 meetings with 3 different webinars and 3 different experts Armando Genazzani, Turin University, the second one with Professor Claudio Iommi, Piedmont University, and the closing one with the speaker I'm going to introduce now, Ramona Belfiore, Ocean, on the Duchenne regulatory science. What is the process that then will take you to the approval of a drug? We have understood that the process is not simple, that it is wrought with difficulties, that there are differences from one side of the ocean to the other. So the rules that apply in Europe do not overlap those that apply in the US. And we have been telling about it in the simplest possible way, and but also being very, very precise on the complexity of the process, thanks to these three outstanding experts who attended the webinars. So the webinars are available on our website because they were recorded, so you can listen to them whenever you have the time to do that. If you go to the parent project, we want to thank Italfarma Roche because they enabled us to organize these three important webinars. But we thought that our conference was also an excellent opportunity to give a sort of summary of what were the three areas we dealt with in the three webinars. And to do that, we invited here the speaker of the last webinar, that is Mrs. Ramona Belfiore Ocean. Thank you for being here with us, and I tell you briefly who she is. She has an incredible CV. She's a colleague, she's a biologist, she's a molecular biologist like me. She trained in Italy, in Sicily, where she also completed a PhD in neurosciences, and then she moved to the States in the area, and she worked in the area of scientific communication and project management, and then she joined a U.S. nonprofit that is called CPATH, and that happened in 2021. They work to accelerate the development of new therapies, and for some months now, she has had a very well-defined focus on DMD and on other neuromuscular diseases. So she works precisely in the area of developing of accelerating the development of therapies, more specifically concerning our disease. I give her the microphone, and thank you very much for being here with us and accepting to attend the webinar, and also accepting to attend our yearly conference. Thank you. Thank you. Thank you, Fernanda, for your introduction. So you said so much. I can go immediately to the subject matter of today. Thank you for your invitation. And so I'm going to make a sort of summary of the three webinars that took place in January, to tell the community in very simple and very general way what are the procedures that lead to EMA approval and up to the arrival of the drug to the patient. Also comparing what are the routes that are followed in the United States and comparing them with what happens in Europe or in the UK and other nations that have different routes or similar routes. It all starts from the need of finding new therapeutical approaches, especially for neurologic pediatric diseases such as DMD. And so there is really a run to understand what are the policies we can carry out to accelerate the development of therapies. So it is very important to understand that what are the regulatory criteria and the revision of these documents that pertain to clinical and preclinical studies. If we start with the first ideas, the one by Professor Armando Genazzani, University of Piedmont, and he summarized the procedures, I mean, the document being sent to EMA, and then what are the criteria used for the assessment. Here is a summary. The summary is in English, but the slide is in English. But as the first item is the risk-benefit definition, evaluation, and determination. And so this is done with different steps. So first, the regulatory level, and then the opinion, the EMA opinion, and then an assessment that is carried out at the national level. For Italy, that will be AIFA, and then the management at the regional level. We're always speaking of the Italian case when we and then we refer to doctors who will prescribe the drugs, and doctors as well will make an assessment of the risk-benefit ratio, and then the patient who takes the drug that will evaluate risk and benefits precisely from the patient's perspective. So Mr. Genazzani made a sort of summary with some examples of the importance of the presence of data supporting safety and efficacy of the drugs. And then he, I mean, there must be a moment of understanding. So, I mean, the developer of a drug, and then EMA, so the regulatory bodies. If we, and then there are the definition of some concepts, scientific advice. At any time in the development of a drug, the producer of the drug can approach the agency and ask the agency suggestions as to the trial design. So all that is included in the trial design, and there it includes number of patients, the presence of placebo, outcomes that are defined and used in the study, and all the components that are present. They can be assessed by EMA before submitting the file to receive an opinion on the safety and efficacy of the drug. If the scientific advice is positive, then this file is submitted with all the preclinical and clinical results on the drug itself, on the drug that is suggested. And here we have a series of evaluators, and these evaluators, each evaluator represent the rapporteur. Well, we have the rapporteur, the co-rapporteur, we have a peer reviewer, and then, of course, EMA that carries out a general review of all the documents that pertains to specific areas, safety, pharmacovigilance, and each of these commissions then will prepare a report and a feedback, essentially depending by large commission or committees rather, that will then give the final opinion. And then there is an opinion by CHMP, and that is, and then there will be a final opinion issued by the European Commission as such. So first of all, you must have enough evidence that the drug has more benefits than risks, that it is safe and effective. So the agency gives a full approval. There are conditions where they understand that the benefits are greater than the risks, but you don't have sufficient data to give a full approval. In that case, the agency will ask for more data to be provided, and so you have this conditional approval. And there are also situations where the target population will never have sufficient numbers to develop statistically significant studies. And in that case, you may have an approval under exceptional circumstances or situations where evidence is not sufficient. And in that case, you have the denial of the approval itself. What are the components that must be evaluated in this case? First of all, the need, unmet needs for a given disease, and in DMD that is quite obvious, and then the therapeutic value versus existing options. So the therapeutic value of this information, of course, comparing it to the existing options. There are considerations to be made also on quality, quantity, and type of evidence required, because in this case, you have observations to be made as to the specific product, the specific drug, as to the number of information required to have that scientific certainty of safety and efficacy. Now, the second webinar was, well, after the approval of EMA, here we're speaking about the use of the drug at the national level. And here Professor Yommi referred to the different steps that are typical of Italy, those that are unique to Italy, and those that are general for European states. First of all, reimbursement costs in general. What is the investment that each nation will make essentially to guarantee that there is a reimbursement of the drug, and that they must consider the general expenditure, the general health expenditure. So there will be a percentage for the reimbursement of the drug, in some states with a ceiling, in other states depending on the therapeutical benefit or the urgency of using that drug. So the steps at the European level move from EMA approval to the a negotiation process, a price and reimbursement negotiation process. This changes from one state to the next depending on the national rules, and there will be an evaluation of the therapeutic power, then the evaluation of this unmet need, and a comparison of proposed value price versus currently available options. So the sustainability in using a drug and reimbursing a drug compared with other available options, if they exist. Some states, for example, the UK, set the thresholds, ceilings for reimbursement, taking into account quality and survival. So also the longevity of the community that has a given disease. Some states, like Italy, only consider unmet need and therapeutic power to set the final price at the end of this negotiation. The timing is different in different states in Europe, and there is not only the time required for the decision-making within each state, but also policies and legal framework of each state for negotiation itself. In Italy, this negotiation may go on up to 1 year, and then after 1 year, there is the sort of distributed decision-making that will be carried out at the regional level. So if we just take into account Italy, we know that the first step is deciding the innovation determination. So there are commissions or committees that will evaluate the EMA-approved drugs in terms of efficacy and safety from the scientific and technical viewpoint. And then there is a commission or rather a committee that sets the price, comparing the product with other therapeutical options or assessing what public expenditure can afford. This year, the two committees were merged into one, so this scientific evaluation is done in one committee only, hoping that this process may accelerate the decision-making process for the approval and reimbursement of the drug. Then you have a regional level. And at the regional level, there are comparisons to be made also in terms of time. There are some regions that will have files that are preset or others that have more rapid procedures to have access to the drug. And so we must also understand how we can manage all that at best. And then regions will decide how to decide who the prescriber will be, where the drug can be available, maybe in chemists, in pharmacies, or if it can be made available only within a hospital structure. So the region will have the task of deciding how to reimburse, and if there is a maximum ceiling, a maximum threshold to be considered, that they also consider the possible reduction of the target. If there is a special urgency for a given target of the population, they may limit the use, or rather the reimbursement of a drug, considering just some subgroups, because they may consider that there is a greater urgency for some targets versus others. But that depends also on the budget of a given region. So there are some ceilings to be considered, considering also all the other drugs that are being reimbursed by a given region. And then here we are. Here is the comparison of interactions among different regulatory disciplines. What happens in EMA and what happens in the United States with FDA, and how the two compare. More specifically, well, in general, we had a look at the key steps for the development of the approval of a drug. So preclinical studies, clinical studies, explaining the regulatory revision process, and also explaining the definition of what we mean by regulatory pathways, how they are distributed depending on the differences between common diseases and rare diseases. Review processes, and they, for example, for rare diseases, include policies and regulations that are specific for rare diseases. And we made a comparison of the different pathways over time to try and understand historically what is the progression of these policies and programs that are available for rare diseases. And the pathways can be similar, but then the enforcement and the timing may differ. And the objective is always trying and facilitate companies in accelerating their discussion with regulatory agencies, and trying and define the concepts of trial design and how they are defined so as to have an optimal pathway. Of course, there are additional pathways that we have summarized here, and it is very important to look at the inclusion of complementary data and data from the real world. We know that FDA has implemented this use of real-world data, especially for follow-up processes, so in the post-marketing surveillance. And here it was possible to use data that come from the real world, so they are collected also in hospitals, essentially, to to confirm that the drug is safe and effective, for example. And here we have a comparison between the US and EMA. EMA has the Darwin project that works in a similar way on the use of data coming from the real world. And both agencies are doing huge steps forward to harmonize their conversation as to the use of this data. We also made a comparison as to the processes pertaining to the assessment both of the drugs and the tools enabling us to decide that a drug is effective and clinically valid. So in FDA, there are processes that are called qualification, fit for purpose, critical path, LOS, and you can send in an application for a support letter on the basis of the scientific support. So these are sort of informal processes. So if there is enough scientific information, say on a biomarker, you can have a discussion as to the criteria to make this discussion fit for purpose. So these are criteria whereby you can specify the measure in such a way that it can be included in the evaluation of a drug. And the same goes for EMA, where there is a qualification process that is adjusted both for biological products and proper drugs. And there are more adaptive pathways considering quantitative processes, and those are included in the qualification pathway. And then there is an informal process, the Innovation Task Force, the ITF, whereby drug developers, researchers can approach the agency to ask for information on an innovative approach that might be included in the evaluation process of the drug in the future. As we see here, here is a summary of the potential approaches that the community can introduce in the regulatory pathway to have also patient engagement mechanisms and involvement of the patient community. As Filippo said before, these are efforts that will move from whole communities, advocacy groups that may have an integrated voice at all steps of development, from the design of preclinical studies to the design of clinical studies, where it is possible to specify what are also the expectations for a trial. And that, of course, is important. It may be included in the final message, how to make something move forward, how to optimize all that so that patients' voices are heard also in the design of the trial. And then some considerations on the call of the whole community to develop global collaborations. We know that there are some institutions, there are collaborations all over. You belong to the greatest collaborations in Europe and the US to make this process move forward, this harmonization move forward in terms of scientific information, but also regulatory pathways. And these communities must get together, work together, so that this information is approached in a very direct and effective way. Of course, this is an example from the organization I belong to. So this is one of the study cases we also have at present, how we can get together coming from different areas, from different backgrounds, to develop methods that can be used in the trial design, such as biomarkers, clinical outcome assessment, or models considering the progress or the natural history of the disease. As you know, many of you are very familiar with that. The Critical Path Institute now has a seat in Amsterdam, so they are developing this idea of harmonizing information, not only from a scientific or regulatory viewpoint, but also as a local presence, trying to harmonize our actions and how we can get to work together and integrate ideas that can then go to legal level and the community as such, as also for the decision pertaining to trial design. And the solution is trying to improve our understanding of the natural history of the disease and also help inform regulatory review, both from the scientific and the logistic viewpoints. So what are the needs the patients may have in approaching a trial enrollment, and how we can optimize the trial design in such a way so as to have more patients being able to participate in the trial. These are innovative systems that can be introduced in the trial design. And of course, you can do all that starting from data coming from different resources, observational studies, but also trials or placebo data. Even placebo data can help us understand what is the natural history of the patient, and so creating useful tools that can be also applied to verify the action of a drug on the natural progression of the disease. Well, key takeaways. Well, especially with regard to harmonization processes. So first of all, policies and regulatory standards and processes. And all the processes that lead to decision pertaining to the safety and efficacy of the drug. Of course, between in different nations, we may have differences in terms of priorities or incidence of diseases. This will be case-specific per disease, but certainly this is information that can be optimized. The assessment, the risk-benefit assessment, may vary depending on the background and, again, the incidence of the disease, and also the submission of application by pharmaceutical companies. They may be different. A company may decide to start at a given point and then submitting the application first to one state and then to other states. This doesn't mean that there is a delay in the evaluation of efficacy or safety, but the timing of application may be different. So the approval may come later in some states versus others. And so data and the type of data that the different agencies ask for, well, may vary. And so this is another area where harmonization would be most welcome. So my call is to all of you to put together all the information we get in the real world, in clinical trials, to try and better design the trials of the future, because this is an aspect that is of paramount importance for us, and it is essential if we truly want to move forward in the therapies for the patients in the future. Thank you. Thank you. questions are welcome. This is a photo of our group for rare diseases and orphan diseases in my organization. I thank all of them for the support they give us in the regulatory work. Thank you.
Grazie moltissimo alla dottoressa Belfiore.
Thank you very much, Professor Belfiore. Any questions? I understand there is one.
Allora,
So, this is a question that I believe many more families would ask you. How come at an international level FDA approves some drugs, whereas EMA approves other drugs, and there does not seem to be, a sharing of this? As for DMD, for example, some molecules have been approved by FDA for exon skipping techniques, which was not the case for EMA, which on the other hand did approve of Ataluren, which FDA did not approve of. So, I mean, how come we have different reactions to theoretically, scientific data? Thank you very much. Well, of course, I'm not here to talk on behalf of any agency, so I will simply try to answer this question based on my membership in a neutral, non-competitive organization. So first of all, the requests might be different. Data can be submitted in a different quantity. The same may happen to outcomes. We know, for example, that some accelerated processes in the US are accelerated because of the presence of surrogate endpoints, which is not exactly what EMA does. So, the clinical benefit is supposed to be evaluated based on a certain number of tools that may indeed pave the way to different decisions. And then, of course, I might add that companies may have never applied to submitting a drug trial, so that policies may indeed change from one company to another, which may indeed influence the final decision of the regulatory body. Another question? Hello. I have recently read an interview of Guido Rasi, former executive director of EMA. Well, in that interview, he said that in the next few years, 20% of drug treatments will be innovative. And he therefore wondered, and I agree, whether, in particular, for some diseases, and in particular when there's no there's no alternative therapy, he wondered whether criteria should change. I mean, when there are alternative therapies, the criteria should be of a given kind. On the other hand, they should dramatically change when there are no alternative therapies, or when, of course, we're talking about a rare disease, and diseases are all important, of course, but I'm talking about the rare ones. So 20% of the treatments to come will be innovative. Okay. So, shouldn't we consider the possibility of changing the guidelines? This is what I'm saying. Well, this is actually coming up, I mean, not everybody can have access to all the information that is published on this issue. For example, the possibility that some aspects regarding, I don't know, AI or machine learning are actually being reviewed. And we know that guidelines are constantly being reviewed, both within FDA and EMA. And we know that more and more debates are now going on with other regulatory bodies from countries like Canada, for example. They all seem to agree about such innovative approaches. But these are precisely the policies that are being considered right now. So as we are speaking here, some studies, some debates are underway in order to better understand this. The breakthrough therapies, for example, account for an area that is precisely being the object of such debates, whereby agencies are supposed to share more and better so that they can accelerate their decision, which is what companies ask for. As for the employment of real-world data, it is of paramount importance since it can help us understand how to move on to the next processes. But when we talk about real-world data, we must realize that these are data to be properly analyzed. So we'll have to be on the safe side, namely when we collect data. We must have them all, and these data must enable us to actually make the right decision on, or a decision for a given drug. So this is really essential to both advancing the innovative processes and the follow-up processes of those that have been started already. So things are going on. We don't seem to be able to see much of that in the near future. But anyway, things are certainly advancing.
Il problema è...
Well, that is precisely the problem. Well, of course, we're talking to you, but we know that you're not responsible for a lot of things. Anyway, now we know that if today a company asks for a post-marketing registry, well, we as academicians are not told anything. EMA a few months ago told me if approval is okay, then we're not interested in the drug anymore. Whereas, as it goes with PTC, we very well know that once the data are reviewed, then the requirements change, and rightly so. Maybe due to other studies being carried out, but that is not part of the request, the baseline request. So we need to have a different set of rules. So some data to be considered as reliable need a certain number of tests. But are we really supposed to wait, say, 5 years for that to happen? So I believe these efforts should be actually accelerated, and maybe there's something we can do about that as a community, because it's really a zero solution. I mean, without any proper indications, we are banned, we are not considered. Well, you're right. and both within the CPATH Institute and the work that we do all the time about data standardization. This is an issue. We need this data to be standardized, to be aggregated. We want to collect them all, as you have rightly said. We want to increase their statistical power, whereby we definitely need robust data so as to be able to test and actually say that a drug is effective. I believe Polarin's initiative will go to this direction for the fit-for-purpose criteria regarding some data for neurological diseases. And the same goes for what we do, where we have a platform for rare diseases, where we precisely work at creating some standards that are reviewed by the regulatory bodies so that we can know what a drug developer should do with a given piece of data to be framed within the whole process whereby the drug is finally approved. We do actually have a database for ataxia, and that was used also to support all the evidence for the approval of any drugs. And we also know that at a regulatory level, all evidence is considered. Therefore, data including the perspective of the regulatory body, of the clinician, the academician, the family, the patient. So all this information should be put together and then should pave the way to a final decision that is grounded. I'd like to thank Ramona. Thank you very much. That was a very interesting presentation. By the way, we have been forced into having 3 webinars, but we wanted to have FDA or EMA representatives here. We did want that also some time ago, but that was very difficult and is still difficult because you must ask for that with many months in advance, and sometimes, by the way, conflicts are cannot find a solution. So we thought we should work differently, namely through the organization of these 3 webinars to be also put in our website. And then we thought these webinars should be summarized at the national conference. The topics involved, by the way, are all very difficult also for the researchers involved. Let me stress what you wrote in one of your slides. Out of 4 innovative systems employed in the U.S., 3 were date back to before the year 2000 and 1 after the year 2000, which is quite different, of course, in Europe, where we are definitely lagging behind. And I believe this may remarkably influence, the final decisions, and we're paying that price. So we as an association did something about that in 2005 and 2009. We held meetings with the EMA people about nucleotides. Well, I believe that the same should be the case in the near future for other possible products. It may be high time we should reconsider it all. First of all, because we don't want to lag behind anymore, but then also because we might want to anticipate some of the problems that might come up. We are all here today. I mean, we as relevant stakeholders are all here, so maybe we can see whether we can work on this in the future. And it's high time we should do that. Otherwise, we'll keep, lagging behind, and even more so. Again, this is something that is being considered. The National Academy of Sciences in the US is precisely considering this, namely by comparing the different policies about rare diseases, for drug approval, both within FDA and EMA. So this is in the agenda, and of course, we'll see we'll have the results hopefully in a relatively short time. So there's the will behind it. We know that agencies, also have in-house processes whereby they keep sharing their data so as to mediate in order to allow all patients to have access to at least similar opportunities. I'm afraid we now run out of time, but again, you can write to our email address. And now Cristina has the floor. But before giving Cristina the floor, once again, thank you very much. Thank you. Thank you.
Siamo arrivati alla fine.
So that's the end. We seem to, have different feelings because we usually start working at this conference in the month of July. So behind a 3-day conference, there's a very hard work that so many people do. I will not go through, the whole list of them, but we have a great staff. So please, let's give a big hand to our staff. So the conference started yesterday, and we first listened to Jacopo. I wish to warmly thank him, together with Ezio, our president. Jacopo said, "We are all tokens of the same puzzle," and I believe this has been made visible by the conference, both yesterday and today. So the tokens of this puzzle are, of course, the parents, namely the founders of our association. As Filippo rightly said this morning, we all stand together, and that's the only way out, by the way. We have been lucky enough as to be part of the staff, and therefore it is an honor for us to do so. And I would personally like to thank you, parents. Thank you for allowing me to do this job. But anyway, the tokens of the puzzle are the parents, of course, the patients, the boys, the clinicians, the staff. But again, another big hand for our clinicians, for our doctors. We seem to learn a lot from each other. Well, I knew nothing of rare diseases. I knew nothing of biology, but in these past few years, I've learned a lot from our biologists. But having said that, whenever we hold meetings with our clinicians, And whenever I hear about the whole mechanism of the disease, well, I always feel enriched by that. So thank you very much. Of course, we'd also like to thank the drug companies. Without them, we would not be able to meet here. So thanks a lot for sponsoring us. We've gone through the whole list of them, but they are on our side all year long. We met some of their representatives last Friday night to talk about the next 3 years. So it's a partnership that is, going on. We want to tell you about the parents' expectations, and you might want to let us know about what can be done altogether. I'd like to thank the speakers and a big hand to our interpreters, without whose work this event could not take place. You can't really see them because they are behind that glass over there, but anyway, their work is precious. So I'd also like to thank our sound engineers. They are very patient with us, and their patience starts, months before the conference. So thank you again. So now there's a box lunch, but please do not leave the room without filling in the form for the continuous donation. I'm sure each one of you will find 50 more donors at home. We, wanted to include this into the, eligibility to getting the lunchbox, but that could not be done. Anyway, thanks again. Thanks once again to our clinicians and the people working in our counseling centers, as we heard from this morning roundtable, which was very special indeed. So please see Emilio at the back, help us move on with our project. Next conference, our 22nd conference, will be held next year. And now let us watch a short video about these 3 days. Thank you.
all you do